Okay, so continuing with our review for immunoserology, let's now have the different concepts with regards to antigen-antibody interactions. Okay, so first, okay, we have to define avidity and affinity. Okay, so the initial force of attraction or strength of the binding between a single combining site of an antibody and an epitope, no, that is found, of course, no, sa antigen, that is what we refer to as affinity. Okay, and the sum total of all of these forces, okay, which I think I emphasized earlier, no, dependent, no, on the valence of the antibody involved, is avidity. Okay, so these interactions are made possible, no, by non-covalent bonds, examples of which are electrostatic attraction, hydrogen bonding, hydrophobic interaction, and van der Waals forces. No? So these are non-covalent bonds. So that means these antigen-antibody interactions or binding can still be they are reversible, no? So that's why in blood banking, elution is possible, no? Yung mga nakadikit na antibodies sa cells, no, we could elute them or we could remove them, considering that the bondings are non-covalent. Okay, so now let's understand the concept of zone of equivalence. And this one is important in order for us to be able to see the visual reaction, no, whenever we do an agglutination or a precipitation procedure. Okay, so the zone of equivalence will be achieved when the number of the multivalent sites of antigen and antibody are approximately equal. Okay, so this is when optimum precipitation or agglutination happens. And sometimes, no, we fail to achieve, no, this zone of equivalence because of what we call the prozone and the post-zone phenomenon. And remember that whenever there is prozone or post-zone phenomenon, this results to a false negative reaction. Okay, so it would result to a false negative reaction because again, the visual reaction can only be seen whenever we reach the zone of equivalence. Okay, now, ano ba yung ibig sabihin when we say prozone phenomenon and what is the cause of it? Okay, whenever there is prozone phenomenon, that means there is an antibody excess. Okay, and the remedy for that is pag masyadong marami yung antibody, so of course what we're going to do is to dilute, no, the serum sample. Okay, so serum dilution is the remedy, no, for a prozone phenomenon. Now pag nagkaroon naman ng post-zone phenomenon, that means that there is an antigen, okay, an antigen excess. Okay, so less yung amount, no, ng antibody. So our remedy for this is to repeat the test, okay, repeat testing. Repeat the test after 1 to 2 weeks. Okay? And the purpose of this is to allow, no, the patient to develop more antibodies. Kasi yan primarily yung reason kung bakit mas konti yung antibodies as compared to that of the antigen. Okay? So again, presence of prozone and post-zone phenomenon will result to a false negative reaction. Okay? Now, let's differentiate precipitation versus agglutination. So, the difference, no, lies in the substances, no, kumbaga, no, that are involved, no, in this reaction. Kasi when we say precipitation, these are reaction between two soluble substances, no. Yung antibodies, remember, humoral component yan, di ba? So yung mga antibodies are soluble and reacting also with soluble antigens, resulting to insoluble complexes. But when we say agglutination, okay, when we say agglutination, this is the binding of antibodies na soluble with that of particulate antigens, no? Particulate antigens. So concrete example of particulate antigens would be our red blood cells, no? Forming cellular aggregates. Now, for both precipitation and agglutination reactions, of course, na yung pinakamagaling dito would be our immunoglobulin M. Considering na it has a valence of 10, it is easy for immunoglobulin M to bridge, no, between antigens. Okay? So, yan yung difference ng dalawa. Now, let's talk about specific precipitation reactions. So, we have 4, no, classification for that. We have precipitation in a fluid medium, precipitation by passive immunodiffusion, we have precipitation by electrophoretic techniques, and sorry, we only have 3. No, we have precipitation in a fluid medium, passive immunodiffusion, and precipitation by electrophoretic techniques. Okay, so first we have precipitation in a fluid medium. So we have here turbidimetry and nephelometry. Okay, so ano ba yung pinagkaiba ng dalawa? No, so basically, no, this involves the use of a light source. Okay, yung turbidimetry, pwede natin siyang maihalin tulad sa spektro. Okay, because what we are absorbing here, what we are measuring here rather, is the amount of light, no, that is being blocked, no, by the solution. So that means, no, that the lower the intensity of the light that is being detected, no, by our photodetector, the higher the concentration of the complexes present in our sample. Okay? Yung pinaka-difference kasi ng turbidimetry and nephelometry is the arrangement, no? The arrangement of the photodetector relative to that of the light source and the sample. Okay? Yung turbidimetry kasi, yung photodetector is positioned along, no, along the light path, whereas in nephelometry, no, the photodetector is positioned at a particular angle. Kasi in nephelometry, what we are measuring here is not the amount of light that is being blocked by the solution, but the amount of light that is scattered by the solution. Okay? So syempre, no, yung amount ng light daw na kinalat, no, ng solution, and that is the reason why we are positioning, no, the photodetector at a certain angle. No, kung gagawa natin yan ng drawing, no, for example, if this is our light source, no, let's say this is our light source, and this is our sample. Okay? When we say turbidimetry, the photodetector is positioned here. Okay? So, basically, no, kung konti yung light na natatanggap ng photodetector, that means marami yung laman ng sample. Okay? Now, in nephelometry, okay, it measures the amount of scattered light, okay, by the substances or the complexes also that are present in the solution. Okay? So pag mas marami, syempre yung nandito sa loob, mas marami yung ikakalat niya na light. That's why in the case of nephelometry, we are positioning the photodetector at an angle, no? Let's say dito natin siya ipo-position. Yan. Because it has to, okay, detect, no, the scattered light. Okay? Now, your nephelometry is more sensitive than turbidimetry. Okay? And oftentimes this is used to measure yung mga macromolecules, no? Not just antigen-antibody complexes, no? But it can also be utilized, no, to measure large substances such as proteins. Okay? So yan yung difference ng dalawa. Okay? Ng turbidimetry and nephelometry. Now, we go to precipitation by passive immunodiffusion. And dito, no, very important na ma-identify natin if whether or not the direction of diffusion is just one way, or if whether or not it's just the antigen that are diffusing or both the antigen and the antibody. That's why meron tayong mga tinatawag na single diffusion in one dimension, double diffusion in one dimension, single diffusion in two dimensions, and double diffusion in two dimensions. Now, ano ba yung ibig sabihin nun? Okay? Pag one dimension, ibig sabihin the direction of the diffusion is just vertical. Okay? Vertical lang yung direction ng diffusion. Okay? That's why pag one dimension, we are usually using a tube or a column. Okay? And what we are detecting here is the presence of the precipitin band, which of course represents the antigen antibody reaction. Now, since tinawag siya na single diffusion, that is because only the antigen, the antigens are diffusing. And the antibody are already layered on the top of the agar. Okay? So single diffusion siya kasi isang component lang yung nagdi-diffuse, and that is the antigen. Okay? One dimension siya kasi nga isang direction lang yung diffusion. Okay? So this single diffusion in one dimension technique, this is otherwise known, okay? This is also known as the Odin's technique. Yan. Okay? Next. Of course, again, the precipitin band will be formed kung saan na-achieve yung zone of equivalence. Okay? Now, we go to the double diffusion in one dimension. So still, it uses a tube or a column because again, one dimension. Isang direction lang yung diffusion, vertical lang. Okay? So still, what we are detecting is the presence of the precipitin band kasi nga precipitation reaction ito. Okay? But this time, it's already double diffusion. So that means both the antigen and the antibody are diffusing. Okay? So nagdi-diffuse itong dalawang ito. Okay? And paano natin to nagagawa, what component of this technique makes the antigen and the antibody to diffuse? That is made possible by the intervening column. Because the intervening column, remember, take note here, it is just a plain agar. So if you are to compare the concentration of this intervening column with the concentration of the agar here, yung concentration niya mababa. Eh di ba meron tayong rule when it comes to diffusion that diffusing particles will always go to an area of lower concentration. So because this area is mababa yung concentration niya, the tendency of the antigen and the antibody, their tendency is to go towards there. Kasi nga mababa yung concentration ng area na yon. So dito sila nagmi-meet, and of course dito din maa-achieve yung zone of equivalence as represented by the presence of the precipitin band. Okay? So yan siya, yung ating double diffusion in one dimension. And this technique is also known as the Oakley-Fultorf technique. Okay, the Oakley-Fultorf technique. Okay, next we have single diffusion in two dimensions. So ngayon, two dimensions na. So if you would notice, pag two dimensions, what we're using a petri dish or a slide. And this is to allow radial diffusion. Ibig sabihin guys, yung pag-diffuse ng antigen dito is hindi lang sa isang direction. It will diffuse in several directions. Kaya siya two dimension. Okay? And still, the positive result would be a precipitin ring. The antibody is incorporated in the agar, and the antigen, most likely, that would be the sample of the patient, is added to a pre-cut well. So then you are to allow this antigen to diffuse, and you measure the result, depending on the type of method that you are using. Because there are two modifications of the single diffusion in two-dimension technique. Okay? One is yung tinatawag natin na endpoint method or otherwise known as the Mancini method. Okay? Mancini or the endpoint method. So bakit siya tinawag na endpoint method? Because you are allowing the antigen to fully diffuse. Okay? So that depends, That depends on the type of antibodies that are incorporated on the agar gel. If the antibodies are IgG, so usually you are allotting 24 hours for full diffusion of the antigen, and 50 to 72 hours naman for IgM. Okay? So the interpretation for this, again, what we are measuring here is the diameter of the precipitin ring that is formed. And the interpretation for the Mancini endpoint method is the square, no, of the diameter is equal to the antigen concentration. Okay? Now, the other method is a method that does not allow full or complete diffusion of the antigen. So it will only allot 18 hours of incubation, tas imi-measure niya na, no? Imi-measure niya na yung diameter ng precipitin ring. This is what we call the Fahey-McKelvey method. Okay, the Fahey-McKelvey method or the kinetic method. Okay, so it will only allow how long? 18 hours of incubation. Okay, so that means it does not allow full or complete diffusion. Okay, or that means it measures, no, the diameter of the precipitin ring. Okay, even before, no, the point of equivalence is reached. No, so how do we interpret this? No, the diameter now, no, the diameter is equal to the log of antigen concentration. Okay, so the diameter daw of the precipitin ring is equal to the log of antigen concentration. So yan yung dalawang uri ng method natin for the single diffusion in two-dimension technique. Okay? And last, no, for the precipitation by immunodiffusion, we have the double diffusion in two-dimension technique. I think among the four technique, ito yung pinaka-importante, which is otherwise known, no, also known as the Oesterlony technique. Okay? So dito titingnan lang naman natin, no, yung shape, no, ng precipitin band, because through that, no, we are able to identify if whether two antigens are identical, non-identical, or partially identical. Okay? So tinawag siya na double diffusion because this time both the antigen and the antibody are diffusing. The antibody is placed, no, on the center well. So dito natin nilalagay yung antibody sa loob. Okay, so most likely that would be the let's say the serum of the patient, and certain antigens are placed, no, on the surrounding well. Okay, and here, no, we are to identify, no, if one or I mean if two of these antigens are identical, no, or hindi, no, based on the shape of the precipitin line, no, that is formed. Okay, so if it has a smooth curve, so that means, no, identical siya. Okay, so ito, no, this is an identical pattern. Okay, if meron namang cross lines, then ibig sabihin non-identical. Okay, if there is a spur, no, that means partially identical, no, yung dalawang antigen na yon. And usually, no, the spur is pointing to the simpler antigen. Again, no, take note natin, no, that the spur is pointing to the simpler antigen. So for example here, no, in this illustration, no, ibig sabihin mas simple yung antigen 3 as compared to that of antigen 1 because the spur is pointing towards, no, antigen 3. Okay? So here's a photomicrograph, okay, of the Oesterlony technique, no? So kung titingnan natin diyan, ito, no, this is the smooth curve na sinasabi natin. So let's say, no, designate natin ng number itong mga antigens na to. Let's say this is A, B. For example, so seeing the precipitin line, no, na ito yung precipitin line, that means itong antigen B tsaka itong antigen F, they are identical. Okay? Antigen B and antigen F are identical. So far wala pa namang nakapag-mention na parang may lumabas na picture, no, for the Oesterlony technique, no. Usually baka magtatanong lang yan sila, no, with regards to the principle. Okay? Usually yung mga pictures kasi lumalabas sa micro, sa CM, tsaka sa HEMA, di ba? So, And last, we have precipitation by electrophoretic techniques. No? So we have two. We have immunoelectrophoresis, and the other one is immunofixation electrophoresis. Basically, no, the purpose of the two is the same. No? Pareho lang yan sila. Usually, we are doing this whenever we encounter a monoclonal gammopathy pattern sa electrophoresis. Kasi di ba pag nagkakaroon tayo ng monoclonal gammopathy na pattern, it is very important for us to identify what protein is responsible for that pattern. Okay? So yan yung purpose nitong immunoelectrophoresis tsaka immunofixation electrophoresis. But between the two, no, yung immunoelectrophoresis kasi is not commonly performed. No, considering na mahirap siyang i-interpret as compared to immunofixation electrophoresis. Tingnan niyo naman dito, no, this is immunoelectrophoresis. So what you're going to do is you are to place, no, an antibody, no, dito sa trough. Tawag natin dito trough. Okay, maglalagay tayo dito ng antibody, tapos lalagay tayo dito ng normal na serum, for example, tapos ito yung patient serum. Tapos maglalagay na naman tayo dito ng antibody, normal serum, patient serum, antibody dito, and so on. Okay? So that antibody, the purpose of those antibody is to be able to detect, no, specific proteins, no? So in this case, this is anti-human whole serum. Yung ibig sabihin ng HWS, anti-human whole serum. So that's why kung matitingnan nyo or makikita nyo, di ba, napakaraming lines, no? Kasi basically buong ano yan eh, it's a mixture of a lot of antibodies. Unlike in this trough, no, na paisa-isa lang, no? So this is anti-lambda, for example, anti-kappa, anti-IgA, anti-IgG. So that means you are targeting, no? Gusto mong malaman if whether the protein responsible for the pattern, for the monoclonal gammopathy pattern, is an IgG, an IgA, a kappa light chain, or a lambda light chain. Now, how do we interpret this? We'll just we're going to compare, no, the shape, no, of the contour, or the shape of the contour of the line, or rather between the normal and the patient serum. Okay? So kung titingnan natin dito, anyway, it's pointed naman by the arrow, no? In this area, okay, there is an abnormality, no, in the normal serum and the patient serum na contour, no? So tingnan niyo naman yung sa patient serum, no? Magkaiba kumbaga yung kanilang itsura. Okay? So that means meron siyang IgG, no? IgG is one of the proteins responsible for the monoclonal gammopathy pattern. And another abnormality here is this one, okay? Yung anti-lambda, okay? So out of this result, we could conclude that the proteins responsible for the monoclonal gammopathy pattern would be IgG and the lambda chains, no? Or the lambda light chains. Okay? Ganun yung purpose nitong immunoelectrophoresis. But again, uulitin ko, this is less performed, no, considering, no, the difficulty of the interpretation. So yung ginagamit natin, no, is this one, no, the immunofixation electrophoresis. So this combines, no, the principle of protein electrophoresis and immunoprecipitation. So you are applying, no, the specimen at 6 positions, no, in the electrophoretic medium, okay, after a monospecific anti-sera is applied directly on the gel surface. So the purpose of this technique, no, is for us to be able to detect, no, the presence of heavy chains such as gamma, alpha, and mu chains, and of course, no, yung kappa at lambda light chains. Okay? The antigen and antibody complexes will be formed kasi nga naglagay tayo ng anti-sera dito. So pwede tayo, naglalagay tayo ng anti-gamma, anti-alpha, anti-mu, anti-kappa, anti-lambda. Okay? And when the antigen antibody complexes will be formed, syempre, it will not be washed off anymore, no? Pag winash natin yung ating electrophoretic medium. Okay, and of course, we have to apply a dye in order for us to visualize, no, the presence of the bands. Okay, so may isang student, no, na naka-mention sa akin, isa daw sa kanyang recall was naka-encounter daw yung medtech ng monoclonal gammopathy pattern, ano daw yung susunod na gagawin? No? And I think, no, I'm really sure that the answer for that is immunofixation electrophoresis. Because whenever there is a monoclonal gammopathy pattern, we have to quantify and identify, no, the protein responsible for the pattern. Okay? So yan siya. So, syempre, magkakaroon din tayo dito ng reference pattern kasi through that, malalaman natin kung anong population siya ng protein. Diba? Okay? So, basically, itong picture na ito, this corresponds with that of this one. Kasi di ba na-identify natin dito that the proteins responsible for the pattern are anti-IgG and the proteins rather responsible for the pattern is IgG and lambda. So dito nakikita natin na meron kang distinct, okay, banding, no, sa IgG tsaka sa lambda region. Okay? That normally dapat hindi present, kumbaga. Or hindi ganun ka-intense. Okay? So, yan yung immunofixation electrophoresis. No? So, sakaling lumabas sa exam ninyo, naka-encounter daw ng monoclonal gammopathy. So far sa choices na binigay niya, wala naman nakalagay na immunoelectrophoresis. No? Sakaling nandun yung dalawa, no? I think you would agree also, no, that the better answer would be immunofixation electrophoresis because it's more reliable and it's easy to interpret. Okay? Now, so that would be all, no, for the precipitation reactions. Now we go to agglutination reactions. Okay, so for agglutination, there are two phases for that. Okay, we have first, yung tinatawag natin na sensitization, kung saan dumidikit pa lang yung mga antibody doon sa antigen. And whenever these complexes starts to form cross-links, okay, there will now be visible aggregates. And it represents already the stabilization of the antigen-antibody complexes with the binding together of multiple antigenic determinants. Okay? Yan yung tinatawag natin na lattice. Okay, lattice formation. Okay, so again, no, pag naririnig natin itong agglutination reaction, no, we have to attribute that to IgM being the most potent, no, antibody, no, when it comes to agglutination reactions. Now, I have included here, no, 6 types of agglutination reaction. One of which, no, lumabas sa aking exam, actually definition lang talaga. Okay? So, the first one here is antigens are found naturally on a particle. So, concrete example, yung ating mga red blood cell. No? Red blood cell is the particle and merong mga antigens that are naturally found in it. No? Example, no? Yung ating mga ABO antigens. Diba? So, yung ating direct agglutination, we could do this actually, no? Yung direct agglutination, this can be done to detect both antigen or antibody. Concrete example is in the performance of ABO typing. Both the forward and the reverse typing are considered direct agglutination. Okay? Minsan ako confused, no? Yung reverse typing daw is indirect, mali. That is still direct. Why? Ano ba yung ginagamit natin sa reverse typing? We are using known red cells with antigens that are naturally found on its surface for us to be able to detect presence of antibody from the patient. Oh, ano yung principle na yun? Direct agglutination. Okay? Kasi wala tayong minomodify eh. No? Wala tayong minomodify. We're just simply making the antigen and the possible antibody react or vice versa. No? The antibody, in the case of the forward typing, no, the known antibody, identifying, no, the antigen na alam naman natin naturally found on the surface of red cells. Okay, in the case of forward typing. Okay, so ABO typing, no, is a concrete example. Okay, ABO typing, as well as yung yung Widal's test. Okay, for salmonella, wherein we are using known antigens, diba, to detect an antibody. Okay, so direct agglutination yan. Next, no, we have it employs particles that are coated with antigens not normally found on their surface. Okay, not normally found no on its surface. So ibig sabihin may minomodify tayo dito. Gumagamit tayo dito ng mga carrier particles. And these carrier particles are coated with antigen. Sinasadya natin na i-coat sila with antigen for us to be able to detect an antibody from the patient sample. So take note, ginagamit natin ito to detect, okay, to detect antibodies. Okay? To detect antibodies. So kumbaga, gagamit tayo ng mga carrier particles. Ano yung mga carrier particles na ito na pwede natin gamitin? Pwede tayong gumamit ng latex, no? Pwede tayong gumamit ng charcoal. Okay? Pwede tayong gumamit ng bentonite. Okay? And we are to coat these particles with antigens. Okay? Para lang ma-visualize natin later on yung reaction. Because they have to be particulate, di ba? Dapat maging particulate sila para matawag mo na agglutination. So ito guys yung lumabas, no? Ito yung recall sa aking exam, no? The answer is passive, no? Passive agglutination. Or pwede mo din siyang tawaging indirect, no? Passive agglutination or indirect agglutination. Yan. Next, baliktad lang, no? Baliktad lang. Instead of coating, no, the particles with antigen, you are coating them with antibodies. So i-coat mo sila with antibodies, that means yung target mo is to detect, no, to detect antigens. Okay? Yan yung tinatawag na reverse passive. Okay, reverse passive agglutination. Okay? Next, we have uses bacterial protein as inert particles to which antibodies are attached. Ano to? This is co-agglutination. Basta narinig na yung term na gumagamit daw ng inert co-agglutination. Okay? Inert bacterial protein, no? Let's say for example, okay, para doon mag-attach yung antibodies, no? So pinakakilala dito guys na ginagamit is the protein A. Okay? The protein A of course, no, Staphylococcus aureus. Bakit natin siya nagagamit? Because yung protein A, no, ng Staphylococcus aureus, it naturally binds. Okay, it naturally binds to the Fc portion, okay, portion of IgG. Okay? So that means no, yung co-agglutination ginagamit natin to detect what? To detect antigen. Okay, ginagamit natin to detect antigen kasi antibody yung nakabind doon sa ating parang carrier particle pa rin, no? But this time it is a bacterial protein. Okay? That's why yung protein A also is one of the virulence factors, 'di ba, ng Staphylococcus aureus. Considering yung action niya, since binabind niya yung Fc portion ng IgG, ano yung mangyayari ngayon? 'Di ba? Pag nabind yung Fc portion ng IgG, there will be no space anymore for complement to bind. Remember, the receptor of complement is also found in the Fc portion of our IgG. Pag ngayon, yung part na yan inoccupy ng protein A, wala nang space para kay complement. Thus, complement will not be activated. So parang nagiging way, no, ng S aureus, no, para to evade, no, yung ating immune system. Okay? Next, we have reactions are based on competition between particulate and soluble antigens for limited antibody combining sites. There is competition. Therefore, pag may competition, kumbaga, indirectly proportional yung magiging expectation natin for that, no? So let's say if most of the time we are expecting that there will be an agglutination, okay, yun yung nagiging positive result. Dito guys, yung absence of agglutination is the positive result. No, the lack of agglutination indicates a positive reaction. No, so tawag natin diyan agglutination inhibition. Okay? Agglutination inhibition. No, so concrete example, no, let's say gumamit ka ng mga red blood cells. For example, so tawag natin doon is heme agglutination. Okay? Heme agglutination inhibition. And usually itong principle na ito ginagamit natin, no, for us to be able to detect antibodies to rubella. Okay, to detect antibodies to rubella, influenza, and respiratory syncytial virus. Then employs an anti-human globulin to detect antibody-coated cells. No, obviously, no, that is the anti-human globulin test. Okay, or pwede natin siyang tawaging anti-human globulin mediated. Anti-human globulin mediated agglutination. So usually ginagamit natin yung AHG, di ba? Especially if the type of the antibody to detect is IgG. Kasi alam naman natin na yung IgG medyo mahina siya mag-bridge, no, ng dalawang cell, for example. So para malaman natin if whether or not nagkakaroon ng sensitization, ibig sabihin if whether or not the cells are coated with antibody, we use another antibody to bridge, no, these antigen antibody complexes. Okay? So yan yung anti-human globulin mediated agglutination. Okay? So kumbaga, if this is a cell, this is another cell, kung titingnan mo, meron naman na talagang antigen antibody reaction, 'di ba? Meron ng sensitization. However, wala siyang cross links. So this will not be visualized, no? Kumbaga hindi ito visible. Okay? So we make use, no? We make use of an anti-human globulin because anti-human globulin will bridge them. Okay? So, yan yung purpose ng anti-human globulin. So that's why it's an antibody, no? It is an antibody against another antibody. Okay? So, this one is otherwise known, no? Yung AHG test natin is otherwise known as the Coombs test. Okay? We'll talk more of this, no, sa blood banking. Okay? Now, let's talk about diseases of the immune system. So first, we have hypersensitivity reaction. Okay, so this is the overactivity of the immune system leading to tissue damage. And we have 4 types of hypersensitivity as classified by Coombs and Gell. Okay, so iba-iba yung kanilang immune mechanism. Okay, and certain conditions or diseases are classified into them. No, so first, we have type 1 or ito yung tinatawag natin na anaphylaxis. Okay, so for type 1, we have cell-bound antibody that are reacting with antigen to release physiologically active substances. Now, sino itong cell-bound antibody na ito? That is the mediator of type 1 hypersensitivity reaction, which is IgE. So itong mga IgE, no, nakikita sila sa surface ng mga effector cells for type 1. Okay? So ito yung IgE for example. Okay? So pag merong nakadikit na allergen for example, no, or antigen dito sa ating IgE, it will trigger, no, the degranulation. Masisira, no, itong mga cells kung saan nakikita yung IgE sa kanilang surface. And yung degranulation of these cells results to release of physiologically active substances that are responsible for the characteristic na signs and symptoms na nakikita sa mga allergic reaction. Okay? So again, cell-bound antibody, IgE, sinong cell? Ano yung mga cells kung saan naka-attach siya? We have basophils and mast cells. Okay? Basophils and mast cells. Now, meron bang complement involvement dito sa type 1 hypersensitivity? Wala. Okay? So you have their examples of type 1 hypersensitivity. We have anaphylaxis, hay fever, food allergies, bee sting, and bronchial asthma. Okay? Now, for type 2, this is otherwise known as cytotoxic. Okay? Type 2 is cytotoxic. So we have free antibody, no? This time not cell-bound, but free antibody reacting with antigens associated with cell surfaces. So sino yung mga free antibody na nire-refer natin dito? We have IgG, no? IgG and IgM. Okay? So these IgG and IgM daw are reacting with antigen associated with cell surfaces. Ano ba usually yung mga cells natin sa katawan with antigen on them? 'Di ba? We have our red blood cells. Okay? We have our WBCs, no, for example. Then we have our platelets. Okay? So since involved dito yung ating IgG and IgM, obviously, no, magkakaroon ng complement activation. Okay? So example of type 2 hypersensitivity reaction includes transfusion reaction, yung autoimmune hemolytic anemia, okay? Hemolytic disease of the newborn, good pasture syndrome, and Graves disease. Okay? So, next, we have type 3. Type 3 is otherwise known as immune complex. No? Immune complex. Okay? Because the reason for this type of hypersensitivity, no, is the deposition of antigen-antibody complexes, no, sa ating mga tissues. So this happens when an antibody react with a soluble antigen and forming these complexes, no, na nagpe-precipitate sa ating mga tissues, usually, no, sa mga basement membrane ng ating mga tissues, and resulting to the damage of host tissue cells. Okay? So still, no, IgG and IgM pa rin, no, yung mga immune mediator dito. Okay? However, this could affect, no, any of our cells, no? So host tissue cells. Okay? And IgG and IgM, so ibig sabihin merong complement involvement. So type 3 includes serum sickness, SLE, rheumatoid arthritis, arthros reaction, and post-streptococcal glomerulonephritis. No? Emphasize ko lang, no, in post-streptococcal glomerulonephritis, hindi naman kasi talaga yung streptococcus yung sumisira dun sa glomerulus mo. But the immune complexes, no, na na-form kasi nag-produce ka ng anti-streptolysin. Okay? So yung anti-streptolysin, or actually guys, hindi lang anti-streptolysin eh. Any antibodies that you produce against Streptococcus pyogenes. Okay? It reacted with Streptococcus pyogenes, let's say mga toxins, let's say yung streptolysin niya, forming an immune complex that later on deposited on the glomerulus of your kidneys, di ba? And yun yung reason bakit nagkaroon ka ng glomerulonephritis. Hindi yung mismong pathogen. Okay, bakit ko ito ini-emphasize? Recall question to sa ASCP exam. May patient daw, no, nagkaroon daw siya ng strep throat. After 2 weeks daw, nag-subject siya sa kidney biopsy. Malamang baka siguro nagkaroon siya ng kidney problem. Hindi ka naman magpapabiopsy ng kidney kung wala problema, di ba? So, nagkaroon siya siguro ng kidney problem. Yung question was, ano daw yung organism na pwedeng makita doon sa kidney? Okay? So, syempre, nandun si Streptococcus pyogenes sa choices. And if you fail, no, to understand, no, the concept of post-streptococcal glomerulonephritis, makukuha ka talaga sa sagot na yun. And you'll answer Streptococcus pyogenes kasi alam mo na nakukos yung Streptococcus infection ng glomerulonephritis. But the answer in that question is none of the above. Kasi yung sumisira sa kidney, hindi yung bacteria, hindi si Streptococcus, but the immune complexes that you form against it. Okay? So, yun, yung type 3. And lastly, type 4, this is the only, no, hypersensitivity that is not mediated by antibodies or immunoglobulins. Because type 4 is mediated by cells. Kaya siya tinawag na cell-mediated or delayed hypersensitivity. Okay, delayed or tinatawag din siya na cell-mediated. Sino yung cell na nag-mediate dito? Of course, yung ating mga T cells. Okay, yung ating mga T cells. Because when these T cells are sensitized, they are actually releasing pro-inflammatory cytokines. No? They release pro pro-inflammatory, okay, cytokines. And these pro-inflammatory cytokines, no, are responsible for the characteristic signs and symptoms, no, associated with type 4 hypersensitivity reaction. Okay? So ano yung mga effector cells natin for type 4? Of course, no, yung ating T cells, and it would also include, no, yung ating macrophages. Okay? Now, magkakaroon ba ng complement involvement? Siyempre wala, no, kasi wala namang antibody diyan na involved. Okay, so example of type 4 would be yung contact dermatitis, the tuberculin skin test, or the PPD. PPD means purified protein derivative test, and pneumonitis. Okay? So yan, no, yung ating hypersensitivity reaction. So para mas madaling tandaan, yung mnemonic lang naman dyan is acid. 'Di ba? Acid. Okay? Anaphylaxis. Okay? Cytotoxic, immune complex deposition, and delayed or cell-mediated hypersensitivity. Okay? Next, another condition or another disease, no, of the immune system would be our complement deficiencies. Okay? So, first is if pag nagkakaroon tayo ng deficiency, no, of the classic pathway, so these deficiencies are primarily manifested by autoimmune phenomena such as lupus. Okay? So nagkakaroon ka ng ng SLE like disease, no? Nagkakaroon ka ng SLE like disease. So usually, no, this happens when you have a deficiency of the classical pathway. So ibig sabihin, deficiency ng C1, ng C2, tsaka ng C4. Okay? Deficiency nila yung magli-lead, no, sa lupus-like symptoms. Okay? Kasi nga, yung C1, C2, C4, mga component yan ng classical cascade. Wala namang, hindi naman sila involved, di ba, sa alternative cascade, yung C1, C2, tsaka C4. Okay? Next, single out ko, no, yung deficiency of C2 and C3. Okay? It leads to recurrent infection with gram-positive encapsulated organisms. Okay? And the most common deficiency is C2, whereas the most severe deficiency is C3. And earlier we have emphasized on kung bakit, no, magiging severe talaga yung problema if you have C3 deficiency. That is because C3 is the convergence point of all of the complement cascades. Lahat sila dumadaan sa C3. Thus, pag wala kang C3, hindi ka magkakaroon any of complement activation. Okay? Good thing, si C3 din yung pinakamarami. No? Siya din yung pinakamarami sa lahat ng ating complement proteins. No? So, maybe the reason why hindi common yung kanyang deficiency kasi hindi siya prone to being deficient kasi napakarami ng level nito. Next, deficiency of the membrane attack complex. So that would be yung ating C5, okay, 6, 7, and 8. No? Pag meron kang deficiency sa mga factors na ito, it could result to recurrent serious systemic infections, especially involving Neisseria species. Okay? Sir, bakit hindi dyan nakalagay si C9? Eh di ba component din siya ng membrane attack complex? That is because you could actually form the membrane attack complex even though wala kang C9. Yung C9, parang pinopotentiate niya lang, no? Or parang pinapalakas niya lang yung membrane attack complex. But the membrane attack complex could be present even in the absence of C9. That's why yung C9, okay, yung C9 deficiency, okay, has no disease association, no, or no known disease. Yung C9 deficiency. Okay? And we have deficiency of the C1 esterase inhibitor, the C1 INH, no? This results to HAE or hereditary angioedema. So if you have this condition, your urinary histamine levels and serum complement 1, okay, levels are elevated during the attacks, whereas your serum CH50, the hemolytic capacity of your classical cascade, your C4 and your C2 naman are decreased. Okay? So, between attacks, C4 is always low, whereas C2 levels are normal. Okay? And take note that the first line therapy for C1 esterase inhibitor deficiency would be C1 inhibitor concentrate. Okay, so let's just include no for C2 being the most common deficiency. C2 deficiency could also result to atherosclerosis. Okay? And of course, pinakakilala, no? Pinaka-importante dito, no? Kasi nagiging recall question talaga to, no, sa ASEP exam. Tinatanong nila in association with flow cytometry, no, yung CD55 and CD59 deficiency. Itong CD55 kasi tsaka CD59, these are kumbaga mga control sila no ng ating complement cascade. Okay? Kasi we cannot I mean naturally, nagkakaroon ng hydrolysis ng C3 components sa ating katawan, especially during nighttime when our blood pH drops. Okay? So, that means no, yung C3 kusa siyang nakikleave into C3A and C3B. And when C3B is deposited on the surface of our normal cells, pwede na siyang mag-activate ng complement. Okay? So, good thing, if our cells are normal, we have inhibitors, kumbaga. No? We have inhibitors of complement activation that are present no, in our normal cells. No? I am referring no, sa ating decay accelerating factor tsaka sa ating membrane inhibitor of reactive lysis. Sino sila? That is CD55, okay, which is the decay accelerating factor, and we have CD59, no, which is the membrane inhibitor of reactive lysis. Now, if you have a deficiency, no, of these inhibitors of the complement cascade, magkakaroon ka ng paroxysmal, okay, paroxysmal nocturnal hemoglobinuria. Yeah. Okay, so I have included there a matrix no for the diagnosis of complement abnormalities. Now, if you have a deficiency no sa C1 components, obviously the classical cascade lang will be affected. No, kasi hindi naman kailangan ng C1 tsaka I mean hindi naman kailangan yung C1 in the lectin and in the alternative cascade. Similarly with C4 and C2, though kasi yung alternative cascade natin binabypass yung C1, C4, C2, and that is the reason pag nagkaroon ka ng deficiency sa C1, C4, C2, yung alternative cascade mo will still be normal. Okay? But if you have a deficiency with this, no, syempre no, magiging low talaga yung lahat ng cascade mo because all of the cascades no require these complement proteins in order for them to go through normally. Parang ganun lang no yung interpretation natin dito. If meron kang deficiency with a complement protein na alam mo is only needed by the classical cascade, therefore it will only decrease no the classical cascade na complement activity. Okay, but if it is a complement protein that is needed by all of the cascades, therefore deficiency of it no will affect all of the cascades in the case of C3. Okay, ganun lang naman yun. Okay, pakidagdag na lang natin dyan if you have a deficiency with MBL and MASP. Remember na yung MASP, that is the counterpart of C1Q, C1R, and C1S no in the case of the mannose binding lectin pathway, magkakaroon ka ng pneumococcal diseases. Okay, associated siya with pneumococcal diseases. Okay? Deficiency naman no, with factor H and factor I results to recurrent pyogenic infections. Okay? And take note, if the sera is improperly handled, no, magiging low yung activity ng lahat ng cascade. Okay? So that's it for complement deficiency. Okay, let's now proceed to immunodeficiency. Okay? So these are defects no of the T and B cell system natin. Okay? First, this one is due to the arrested differentiation at the pre-B cell stage, okay, leading to complete absence of B cells, plasma cells, and immunoglobulin of all classes. The underlying genetic mechanism here is you do not have the enzyme BTK. BTK is otherwise known as Bruton's tyrosine kinase. No? BTK here means Bruton's, okay, Bruton's tyrosine, okay, kinase. Yeah. So obviously, no, this is Bruton's agama, okay, Bruton's agama globulinemia. Yeah. Bruton's agama globulinemia or tinatawag din ito na X-link. Okay, X-link agama globulinemia. So natural kasi kumbaga dito yung nangyayari hindi nagma-mature yung B cells mo, yung mga developing B cells mo. So natural, wala kang B cell, wala kang plasma cell, walang magpo-produce ng antibodies. Kaya wala kang antibody, kaya gamma globulinemia. Okay? Next, the most common congenital immunodeficiency that is usually asymptomatic and is characterized by lack of IgA pero normal yung IgM and IgG mo. So ibig sabihin selectively lang, IgA lang yung deficient. Tawag natin doon is selective IgA deficiency. Next, this involves a developmental abnormality of the third and fourth pharyngeal pouches that affects the development of the thymus, resulting to a quantitative T cell defect. Okay, so this is a T cell defect. So this is characterized by tetany and cardiac defects, especially if the neonates are severely affected. This is referred to as the George, okay, the George anomaly. Okay, so take note, it is a quantitative T cell defect. Okay, next, it is a rare X-linked recessive syndrome that is defined by the triad of thrombocytopenia, mababa yung platelet levels mo, eczema, and recurrent infection. Minsan, gagamitin nila yung term na immunodeficiency instead of recurrent infection. So, kumbaga daw, you are characterized by a triad of thrombocytopenia, eczema, and immunodeficiency. That is the Wiskott-Aldrich syndrome. Okay, Wiskott-Aldrich syndrome. Okay, so take note of the triad, very important. So this results to an abnormality in both the cellular and the humoral immunity. Okay, another is a rare autosomal recessive syndrome characterized by chronic sinopulmonary disease, cerebellar ataxia, small dilated blood vessels of the eyes and skin, malignancy, and progressive neurodegeneration, that is ataxia telangiectasia. Okay? And lastly, considered to be the most serious congenital immunodeficiency wherein both of your T and B cell functions are affected. Okay? And this is characterized by severe infections that are fatal within the first 2 years of life if treatment is not applied. No? So this is severe combined immunodeficiency or SCID, no? Yung SCID. Okay? So I think more than anything, no, yung pinaka-importante dito is for us to identify na sa Brutons tsaka sa selective IgA deficiency, sino yung lymphocyte population na affected? Si B cell. Sa DJORD, si T yung affected. Yung Wiskott-Aldrich, ataxia telangiectasia, and severe combined deficiency, syempre yung affected dito would be both the B and the T cell. Okay? So I think yan yung importante dyan. Okay, so we're done with the different immunodeficiency states. So kung merong immunodeficiency, syempre meron ding immunoproliferative disorders. Okay? So we have here first yung monoclonal gammopathies. So monoclonal gammopathies, these are a group, no, of disorders characterized by abnormal proliferation of clonal cells resulting to a production of proteins, okay, such as intact monoclonal immunoglobulin, free light and heavy chains, and these proteins, no, are usually responsible, no, for the pattern na nakikita natin sa serum protein electrophoresis, no, yung monoclonal spike. Okay? So usually, no, itong presence ng protein na to is referred to as the M protein, the M band, the M spike, or the monoclonal spike, para protein or Benz-Jones protein. Okay? So yung monoclonal gammopathies, this could result from disorders ranging from low tumor burden, pre-malignancy states, and malignancies. No? So hindi siya specific lang na condition. No? So it could result, no, from several conditions. Okay? That's why I've been emphasizing earlier that whenever we encounter a monoclonal spike, no, we have to identify kung ano yung specific protein na ito. Kasi pwede siyang intact monoclonal immunoglobulin, pwede siyang maging free light, or pwede siyang maging free heavy chain. And we have to identify that. Okay? So that ulitin ko ha, no, whenever there is monoclonal gammopathies, no, very important consideration for diagnosis is quantification, okay, quantification and identification of the protein involved, or sabihin na natin of the M protein. Okay? Next, we have multiple myeloma. So multiple myeloma develops in activated memory B cells or plasmablasts. Okay? So there is a chromosomal translocation between the immunoglobulin heavy chain and an oncogene, and that is the frequent, no, reason, no, for this condition. So a single plasma cell clone proliferates, producing cytokines that results to localized damage or antibodies, no, that are depositing in various organs of the body. Okay, so that is Waldenström multiple myeloma. So take note, it develops, no, in activated memory B cells or plasmablasts. Next, we have Waldenstrom macroglobulinemia. This one naman is a lymphoblastoid cancer. So Waldenstrom macroglobulinemia cells produce large amounts of IgM, and these cells reside in the bone marrow where they crowd out normal cells. Okay? So because of the large amounts of IgM that is produced, no, if you have Waldenstrom macroglobulinemia, that's why itong sakit na to is associated with hyperviscosity syndrome. Okay? Hyperviscosity syndrome. Next, we have light chain amyloidosis. No? So, clonal population of plasma cells producing monoclonal light chain, no, of the kappa or lambda type. No? So, it's only affecting, no, the kappa and lambda light chains. So, amyloidogenic light chains misfold, forming beta-pleated sheets, and these light chains deposit in tissues in the form of amyloid fibrils. And these deposits result to interference, no, with the normal structure and function of our organ. Okay? And lastly, we have the X-linked lymphoproliferative disease. Okay? Wherein affected individuals produce abnormally large numbers of T and B cells when they are infected with Epstein-Barr virus, resulting to a life-threatening reaction referred to as the hemophagocytic lymphohistiocytosis. Okay? So kumbaga, no, the manifestation of the disease will not be evident unless, no, the patient is infected with Epstein-Barr virus. Okay? So this condition is otherwise known, no? Tinatawag din ito na Duncan disease. Okay? Otherwise known as Duncan disease. And it's important to note, no, that this condition could result also, no, to an inverted, okay, inverted CD4 CD8 ratio. Okay? And pwede din kading maka-experience ng hypo, okay, gamma globulinemia. Okay? So that would be all for immunoproliferative disorders. And next, we have autoimmune diseases. Okay? So yung autoimmunity, okay, this is a result of the loss of self-tolerance, no, ng ating immune system. Okay? Earlier when we are discussing about the development of B and T cells, I was mentioning about the selection process. And there are two types of that, or there are two phases, no, of the selection process. Okay? We have the positive selection and the negative selection process. Okay, the positive selection, and we also have the negative selection process. So ano ba yung ina-assess, no, in the positive selection process, no? So kumbaga, no, pwede natin tong isipin na yung mga nagde-develop natin na lymphocytes, parang binibigyan sila ng exam, parang ganun. Okay, para malaman or para bago sila parang nagbo-board exam din sila, no? Para malaman if they are ready na to practice, parang ganun. Okay? So in the positive selection process, what we are checking here is the ability, no, the ability of the developing lymphocytes to bind antigen. Okay? So the ability of the cell, no, or the lymphocyte to bind an antigen. Okay? So that means, no, paano natin to ma-assess? This will only be possible if there is already complete TCR in the case of your T cell, or IgM, no, in the case of your B cell. Kasi itong T-cell receptor tsaka yung IgM, they have to be present in order for the cell to be able to bind to an antigen. So yan yung first part ng exam, kumbaga, no, the positive selection. Now, in the negative selection process, ina-assess natin dito if whether or not the cell is able to recognize self-antigen. Okay? If the cell is able to recognize self-antigen. If that antigen is self, supposed to be yung lymphocyte, hindi niya ito ibabind. Okay? Normally, T and B cells, okay, will not bind, okay, self-antigens. Ngayon, kung ikaw, no, isa kang B cell for example or isa kang T cell and you bind, no, to a self antigen, ibig sabihin hindi mo na-recognize 'yon. Okay? So, you are not allowed to pass and you will be killed, no, through the process of apoptosis. Sa katunayan, no, very intense itong positive and negative selection process that 90% no, of developing B cells, okay, 90% of developing B cells and 97% of developing T cells are killed, no, through the process of apoptosis kasi hindi sila pumapasa sa selection process. And ngayon, no, dito natin nakikita na very important itong selection process because ito guys, so, if you are not able to recognize yourself and pumasa ka sa selection process, that's the reason bakit nagkakaroon ng autoimmune diseases, no? You are producing an antibody against your own antigen. Okay? So, for the autoimmunity, I think yung importante dito is to identify the autoantibody. No, yun yung lumalabas sa exam. Ano yung autoantibody na associated with this disease or pag meron kang ganitong disease, ano yung autoantibody na makikita mo, baliktad lang nila yung tanong. Okay? So, autoimmune diseases no can be organ specific and it could be systemic, no. So inarrange ko to from those diseases that are organ specific and yung nasa huli sa list na to are the systemic ones. Ibig sabihin it affects no the entirety of the body. And majority no of our autoimmune diseases are mostly prevalent no sa mga babae no of reproductive age. Okay? So what are the possible no mechanisms no kung bakit nagkakaroon no ng autoimmunity? Number one, molecular mimicry. Okay? So merong mga, let's say merong mga pathogens no that are mimicking naturally present antigens no in our body, or kumbaga binimimic nila yung ating mga self antigen. So because of that, no, your body will produce an antibody na dapat sana para dun sa pathogen na yon. But since it mimic your self antigen, that antibody will cross-react, okay? It will cross-react with your own, okay, antigen. Okay, so that is for molecular mimicry. Next, we have direct stimulation of autoreactive cells no, by the presence of foreign antigen, dysregulation of cytokines, and increase MHC expression. Okay? So, iisa-isahin natin itong mga autoimmune diseases natin and let's identify kung ano ba yung mga risk factors, okay? And the autoantibodies present. So, first, we have ankylosing spondylitis. So this is one of the autoimmune diseases that are affecting males more than females. Kasi generally, yung mga babae yung pinaka-affected, but in the case of ankylosing spondylitis, yung mga lalaki. No? So this one begins in the sacroiliac joints causing vertebral fusion. So medyo nakukuba yung mga taong may ankylosing spondylitis. And earlier we mentioned that the strongest no genetic risk factor for this is your HLA B27. Okay, so this one is a strong genetic risk factor, okay, for ankylosing spondylitis. Next, we have autoimmune Addison disease. So you have antibodies to adrenal antigens resulting to adrenal insufficiency leading to hormonal imbalances. No? So let's not forget no, na pag nagkakaroon tayo ng Addison disease, nagkakaroon ka ng deficiency for example sa cortisol mo, sa aldosterone mo, okay? So it would result no, to hypoaldosteronism, eventually hyponatremia din. Okay? Anyway, mapapag-usapan natin yan sa chem. Okay? So, yung recognized genetic risk factor naman no, for autoimmune Addison disease is HLA, okay, DR B1 0404. So this is the recognized, okay, genetic risk factor. Yeah. Next, we have Graves' disease, one of the autoimmune thyroid condition. So you have anti-receptor antibodies to TSH receptor. So itong mga anti-receptor antibodies na to, we also refer them as thyroid stimulating immunoglobulin or TSI. Yan yung ibig sabihin ng TSI. Okay? Okay, so again, yung Graves' disease, is there is presence of thyroid stimulating immunoglobulin. So itong mga thyroid stimulating immunoglobulin, from the name itself, nagpapanggap sila na para silang mga TSH, no? Eh di ba yung function ng TSH is to stimulate the thyroid gland to produce thyroid hormones. And syempre, yung thyroid gland natin, nagfa-function to through feedback mechanism. Pag mataas na yung level ng thyroid hormone, dapat magiging mababa na yung level ng TSH. But in the case of magiging mababa na yung level ng TSH and the thyroid hormone production will stop. But in the case of Graves' disease, yes, bumababa yung level ng TSH, but you have this substance that pretends to be TSH. That's why continuously na-activate yung thyroid gland mo to produce T4. So that's why yung Graves' disease is characterized by low thyroid stimulating hormone but increased T4. Okay? So maka-classify natin siya na primary, okay, hyperthyroidism. Okay? Next, we have Hashimoto's thyroiditis. Okay? So T helper cells, yung CD4 positive cells natin, react to specific thyroid antigens, and as a result, nagtatawag siya ng T cytotoxic cells, and these T cytotoxic cells destroy the gland tissue. Okay? So as a result, yung thyroid gland mo hindi na makapag-produce ng thyroid hormone. So since mababa yung thyroid hormone mo, nagre-respond yung pituitary gland mo dito. Okay? Naiisip ng pituitary gland mo, uy, mababa yung thyroid hormone. Sige, mag-produce ako ng TSH in order for me to stimulate the thyroid gland. But remember, the thyroid gland is already destroyed. Therefore, kahit gaano pa kataas yung TSH, your T4 will no longer be elevated. Okay? Magiging mababa pa rin yung T4 mo. So, that's why yung Hashimoto's is classified to be primary hypothyroidism. Okay? Primary hypothyroidism. Now, ano ba yung mga antibodies that are associated with Hashimoto's thyroiditis? Tatlo. We have antimicrosomal antibody. Okay? Antimicrosomal antibody. We have antithyroglobulin. Okay? Antithyroglobulin. And we also have antithyroid peroxidase. Okay? Antithyroglobulin and antithyroid peroxidase, or pwede siyang i-abbreviate as anti-TPO. Now, recently, isa sa mga kasama natin sa Cerebro took the exam. He took the exam sa US and nag-send siya sa akin ng recall. Isa sa mga tanong niya is, ano daw yung autoantibody na nakikita sa Hashimoto's thyroiditis? Tapos sabi niya sa akin, sir, medyo sumakit na ulo niya kasi both antithyroglobulin and antithyroid peroxidase are present sa choices. Eh di ba pareho silang nakikita sa Hashimoto's thyroiditis? Okay? So sakaling lumabas yan sa inyong exam, okay, choose anti-TPO because anti-TPO is more common or more frequently found in cases of Hashimoto's thyroiditis as compared to antithyroglobulin. Okay? So that is Hashimoto's. Next, we have chronic active hepatitis. There are two types for this. Type 1 is the classic, the classic chronic active hepatitis that accounts for approximately 96% of the cases in the United States. And this type of chronic active hepatitis can occur at any age. And HLA-DRB103 and HLA-DRB104 are identified genetic risk factors. Also, this type of chronic active hepatitis is will also give a positive result for anti-nuclear antibody staining because nagkakaroon din ng presence of anti-nuclear antibodies. And of course, yung anti-smooth muscle antibody. Okay, anti-smooth muscle antibody. Now, there is the chronic active hepatitis also has a type 2, and this one is common in Europe. Okay, it is common in children and young people, and it is relatively severe as compared to type 1. Okay, so ano naman yung mga autoantibodies that can be found in type 2? We have the anti-LKM1. Okay, anti-LKM1. Anti-LKM1 is this is anti-liver, kidney, microsomal antibody type 1. Yeah. Okay. Then another autoantibody that is found in type 2 chronic active hepatitis is the anti-LC1. Okay? Anti-LC1 naman is anti-liver, okay, cytosol type 1 antibody. Okay? So that's it for chronic active hepatitis. Pero ito yung pinaka yung pinaka parating ina-associate talaga, Anti-smooth muscle antibody daw associated with what disease? Chronic active hepatitis. This is a high-yield topic, guys, in the ASCP exam. Sa katunayan, I think during my exam, parang mga nasa 3 yata yung tinanong from this. Okay? Next, we have primary biliary cirrhosis. So this one is an organ-specific disease targeting the biliary epithelial cells. And kung meron tayong tatandaan dito na antibody, that would be the anti-mitochondrial, okay, anti-mitochondrial antibody, that is usually present in 90% of the cases. Next, another organ-specific disease that targets naman the bile ducts is primary sclerosing cholangitis. Okay? So in this disease, pwede kang magkaroon ng abbreviate ko na lang pwede kang magkaroon ng ANCA. ANCA is anti-neutrophilic cytoplasmic antibody. Pwede ka ding magkaroon ng anti-nuclear antibody. Pwede ka ding magkaroon ng anti-smooth muscle antibody. Okay? So these antibodies are common in people with primary sclerosing cholangitis. However, they are non-specific. Obvious naman. Kasi itong mga antibodies na ito, nakikita din sa ibang mga disease. Okay? Next, we have Goodpasture syndrome. Okay? So it's also an organ-specific disease that targets the kidneys and the lungs. Okay? So it causes glomerulonephritis and bleeding in the lungs. That's why nagkakaroon ng dugo yung sputum mo. Yung tawag natin doon, hemoptysis. Okay? So sino yung antibody na associated dito? That would be the anti-glomerular, anti-glomerular basement membrane antibody. Okay? So, tinawag siya na anti-glomerular basement membrane antibody, but do not forget that it could also attack the lungs, because actually itong anti-glomerular basement membrane antibody, yung target nito, it targets collagen. Yeah. Okay? Next, we have myasthenia gravis. It is a neuromuscular disease characterized by muscle weakness, and the associated antibody is anti-acetylcholine, anti-acetylcholine receptor antibodies. Okay? Next, we have pernicious anemia. No? So this is an organ-specific disease targeting our parietal cells. However, pernicious anemia have two types. No? Yung type 1, the types depends on the antibody present. Kasi pag type 1 na pernicious anemia, your antibody is anti-intrinsic factor. Okay, anti-intrinsic factor. Yung type 2, yung antibody na present sa iyo is anti-parietal cell. Okay? Antibody. And type 2 is more common. Okay? As compared to type 1, no? Kasi nasa 90% siya. Okay? Of the cases of pernicious anemia. So syempre kilalang-kilala natin 'to, no? Kasi if you have an anti-intrinsic factor or if you have an anti-parietal cell antibody, the point here is magkakaroon ka ng intrinsic factor deficiency. Now, what do we know about intrinsic factor? We need that in order for us to absorb vitamin B12. So nagkakaroon tayo dito ng vitamin B12 deficiency resulting to megaloblastic anemia. Okay? So yung pernicious anemia is one of the causes, no, of megaloblastic anemia. Yung mga megaloblastic anemia, these are the anemia that are caused by vitamin B12 or folate deficiency. Okay? Next, we have progressive systemic sclerosis. Okay? This is a systemic disease affecting the skin, the subcutaneous tissue, and smooth muscle, characterized by changes in texture and appearance of the skin. Okay? Mas kilala natin to sa tawag na scleroderma. Okay? Eh di ba yung scleroderma, siya yung S, no, sa crest. Okay? Yung scleroderma sa crest. Yan. Okay, so what are the antibodies no present here? Of course, magkakaroon ka ng anti-nuclear antibody. Siyempre, yung pinakakilala for this is the anti-centromere antibody. Okay? Then, magkakaroon ka din ng scleroderma antibody. Yan yung ina-abbreviate na SCL70. Okay? So itong tatlo, these are the common, no? These are the common autoantibodies associated with scleroderma. Okay? Next, we have rheumatoid arthritis, no? This yung rheumatoid arthritis tas pababa, these are already systemic, no? Mga systemic na ito na autoimmune disease. So this is the most common form of chronic inflammatory arthritis, and other manifestations of rheumatoid arthritis includes interstitial lung disease, pleuritis, endocarditis, and systemic vasculitis. So ano yung mga tatandaan natin, no, that are possibly present, no, sa rheumatoid arthritis? Of course, yung ating rheumatoid factor. And ano ba yung nature ng rheumatoid factor? Lumalabas to sa ASCP exam, pakilagyan ng star. Rheumatoid factor is an IgM, okay? IgM directed, okay? Directed towards, okay, the Fc portion of an IgG, no? So it is an IgM directed towards the Fc portion of an IgG. Also, if you have rheumatoid arthritis, no, the CRP and the ESR levels are also increased because this is useful, no? Useful ito, okay, in differentiating from osteoarthritis. Okay? So if you want no to differentiate no rheumatoid arthritis no from osteoarthritis, we could look no at the CRP and ESR levels being increased in the case of rheumatoid arthritis. And of course, magkakaroon ka din ng anti-nuclear antibody, no? It may also be present. But the antibody, no, that we are really to remember here, no, pag meron kang rheumatoid arthritis, is the anti-CCP or cyclic, the cyclic citrullinate peptide, the cyclic citrullinate peptide antibody, okay, that are usually no yung anti-CCP, okay, that are usually present no sa 60 to 70% of RF negative individuals, no? Lagay ko na lang PX patients. Okay? So that means hindi lahat ng taong may rheumatoid arthritis automatically magkakaroon ng rheumatoid factor. No, there are people no with rheumatoid arthritis that are rheumatoid factor negative. Okay? And in 60 to 70% of these people, meron silang anti-CCP. Next, we have Sjogren's syndrome. This is a disease that attacks the glands that make tears and saliva, as well as other body systems including joints, thyroid, kidneys, liver, lungs, skin, and nerves. Okay? So in the case of Sjogren's syndrome, this is common. Okay? This is common in women na greater than 40 years of age. Okay? Common in women of greater than 40 years of age. Okay, so yung Sjogren's syndrome, ano yung mga palatandaan natin na antibody dito? Yung tinatawag na anti-SSA or yung RO. Okay? And we have anti-SSB. Okay? Ito yung LA. Okay? So these antibodies are frequently positive no sa mga patient with Sjogren's syndrome. Okay? Okay, frequently positive. But other than these, no, yung anti-SSA and anti-SSB, again, pwede ka din dito magkaroon ng anti-nuclear antibody, pwede ka din magkaroon dito ng rheumatoid factor, pwede ka din magkaroon ng anti-double-stranded DNA. Okay? Next, we have granulomatosis with polyangiitis. So this one is a disease characterized by inflammation of blood vessels of respiratory tract and kidneys. And the immune-related laboratory testing, we have CRP and ESR. ANCA antibodies are common. Okay, but remember that ANCA antibodies are non-specific because they can also be present no, in other conditions. Now, the reflex positives for this would be a positive result no, for anti-proteinase 3 or the anti-PR3 that is a predominant no, finding in people with this condition. And pwede din silang magkaroon ng anti-MPO, no? But that is less common as compared to anti-proteinase 3. Yung sakit na ito ay mas kilala natin sa tawag na Wegener's granulomatosis. Okay, Wegener's granulomatosis. Next up, last we have, of course, no, yung systemic lupus erythematosus. So this is a systemic rheumatic disorder wherein you have or you do not have the ability to clear immune complexes resulting to tissue injury. Again, whenever there are immune complexes that are deposited all throughout our body, our body will try to eliminate them. As a result, nasisira yung mga surroundings ng immune complexes na ito. Okay? So because there is a continuous deposition of immune complex, there is also a continuous activation of the complement. And as a result, no, some of your complement proteins become depleted. Okay? Yung C3 is pinaka-affected dito because other than it is consumed, no, you also have an autoantibody, C3 nephritic factor, if you have systemic lupus erythematosus. But the two autoantibodies, no, that we have to really remember when it comes to SLE, the hallmark is anti-double-stranded DNA. Okay? This is considered to be the hallmark of the hallmark of SLE. Okay? Kasi these autoantibody is rampant siya, very frequent siya when it comes to SLE. And we have another that is also specific, no, for SLE. Yan yung tinatawag na anti-Smith, no, or anti-SM. Ito naman guys, sa SLE lang to nakikita. But hindi siya ganun ka-frequent because this is only seen in 20% of the cases. Okay? But one thing's for sure, no? Pag meron kang SLE, okay, for sure magiging positive ka talaga sa ANA. Bakit? A negative ANA, take note, a negative ANA, okay, excludes. Okay, a negative ANA excludes SLE, no, from the diagnosis. So hindi pwede na may SLE ka tas negative yung anti-nuclear antibody staining mo. Magiging positive ka talaga doon. Either it will be caused by the presence of anti-double-stranded DNA or it will be caused by the presence of anti-Smith. Okay? So, ito no yung ating mga autoimmune diseases. We are to connect this, no, sa ating mga ANA patterns. Okay? Kasi very common din yan, no, sa ASCP exam. Bibigyan ka ng picture, tatanungin ka kung ano yung antibody na responsible for the pattern or tatanungin ka kung most likely ano daw yung disease ng patient na may ganong pattern. Okay? Okay, so continuing, we now have transplantation immunology. So first, let us have the different categories of transplant donors. First, if the patient receives own cells or tissue bank, no, ibig sabihin nun, it is classified as an autograft. Okay? So, example is yung mga skin graft, no, na nilipat sa isang part ng katawan mo, let's say to replace, no, yung damaged skin, for example, no? That is an autograft. Next, a patient receives graft from a family member or unrelated individual. Okay? So, basically, you receive an organ or a graft from another individual but of the same species. Okay? So yan yung tinatawag natin na allograft or also referred to as homograft. Okay? Then, a patient and donor are identical twins. So that is referred to as isograft. Okay? Isograft. Or the other term is syngeneic graft. And lastly, patient receives a graft from another species. No? So that would be xenograft or heterograft. Yeah. Okay. Now let's talk about transplant rejection. Okay, so we have 5. First is yung pinakamabilis, no, which could occur minutes to hours after the vascular supply to the transplanted organ is established. Okay, so oftentimes, no, isa sa mga pinaka-cause nito would be ABO, incompatibility. Okay? Kasi syempre, dahil mabilis ito because you already have preformed antibody that reacted with the organ, no, that is given to you, no. So ito yung tinatawag natin na hyperacute rejection. Okay? Hyperacute rejection. Next, this type of rejection may take place over several days. This occurs in individuals possessing very low levels of preformed donor-specific antibody. No? So, yes, you have preformed antibody, but maybe because the levels are low, hindi siya nag-react right away. No? So, ito yung tinatawag natin na accelerated rejection. Next, occurs days to months after the transplant. This is mediated by a cellular allo response wherein CD4 positive T cells produce cytokines and CD8 positive T cells mediate cytotoxic reactions. So antibodies produced against HLA antigens bind to vessel walls, activate the complement, and induce transmural necrosis and inflammation. Okay, so this is acute rejection. Next is the most common, or considered to be the most significant cause of graft loss after the first year post-transplant. No? So kumbaga, for a certain period of time, inakala mong tinanggap na ng katawan mo yung graft. But usually, this is a result of imbalances, no? Or nagkaroon ng disturbance, no? Between the host-graft relationship. And it results, no, from a process of graft arteriosclerosis characterized by progressive fibrosis and scarring with narrowing of the vessel lumen due to proliferation of smooth muscle cells. So kumbaga nai-impair din yung blood supply to the organ, and later on, okay, you lost the graft, no? So ito yung chronic rejection. Okay? And lastly, no, this one may occur after 100 days post-transplant or more, wherein T cells in the hematopoietic stem cell, lung, or liver transplant react against foreign HLA proteins in the recipient's cell. Okay? So kung baga, no, ina-attack yung cell ng tumanggap ng graft. Okay? Causing massive cytokine release, inflammation, and tissue destruction in various locations throughout the body. So this is graft versus host disease. Because usually merong mga immunocompetent T cells, no, that are present in the graft that eventually attack, no, the cells of the recipient or the host. Kaya siya tinawag na graft, no, versus host disease. Okay, or yung GVHD, no? Graft versus host disease. Yeah. Okay, next we have tumor immunology, no? So parang similar to guys, no, with the autoantibodies earlier, no, that we are discussing. It's also important din na maging familiar din tayo and what are the cancer, no, that are or malignancies that are usually associated with these tumor markers, no. But first, let us not forget, no, the main usefulness talaga or clinical utility of tumor markers is to check, no, for recurrence. Okay, ito talaga yung pinaka-significance ng mga tumor markers. Yes, no, they may be used, no, for diagnosis, no, but not all of them, no. So however, no, hindi din sila ginagamit for treatment for sure, no. Pero 'di ba merong mga ibang cancer kasi na kailangan talaga ng biopsy, no, in order for it to be diagnosed. Okay? Pwedeng gamitin itong mga tumor markers for screening, pwede. Sorry pala, no, they cannot be used rather for diagnosis but for screening. Okay? Pero yung pinaka-significant use niya is to check, no, for recurrence of cancer, especially after a treatment is already done. Let's say nagkaroon na ng what do you call this, operation, no, na remove na for example yung tumor, okay, or the organ affected, no, pwedeng mag-recur yung cancer. Okay, so ginawa kong blank dyan yung mga pinaka-importante. First, we have alpha-fetoprotein. This is a tumor marker for hepatocellular carcinoma. Okay, hepatocellular carcinoma, testicular cancers, and germ cell carcinoma. Next, we have ALP. No, ALP. Remember, this is the enzyme, no, that is often utilized to be a tumor marker. No, specifically, no, yung isoenzyme ng ALP that is used for lung cancer is the Regan. No, the Regan isoenzyme. Okay. Amylase, no, can be used for pancreatic cancer. Benz-Jones protein, of course, for multiple myeloma. Then we have BRCA1 for breast and ovarian cancer. Of course, yung mga CA natin, CA125, this is for ovarian cancer. CA15-3, this is for breast cancer. CA19-9 naman is for pancreatic cancer. But not just that, pwede din siya, no, for gastric. Okay? Pwede din siyang i-utilize for gastric and colorectal cancer. Then we have calcitonin. This is a tumor marker for medullary thyroid carcinoma. Okay. CEA, of course, for colorectal cancer. Stomach, breast, and lung cancer. Then we have NMP. NMP, ibig sabihin nito is nuclear matrix protein. Okay? Ibig sabihin ng NMP is nuclear matrix protein. And this is associated, no, with urinary bladder cancer. Of course, PSA, no, this has replaced the use of acid phosphatase. No? Dati kasi acid phosphatase yung ginagamit usually to check if mayroong malignancy for the prostate. No? But now, it ni-replace siya ng mas specific, no, na antigen, no, that is the prostate. Okay, specific antigen. And lastly, no, we have CIFRA 21-1. CIFRA means cytokeratin fragment. Okay, yan yung ibig sabihin ng CIFRA. Cytokeratin fragment. Yan. 21-1, okay, pwede siya for lung cancer as well as for breast cancer. Okay? Yung CA pala, no, yung ibig sabihin ng CA, yung pinakatamang ibig sabihin niyan is carbohydrate antigen. Okay? Carbohydrate antigen. Pero parang ina-accept na din, no, yung term na cancer antigen for that, no? Kasi nga nagagamit siya as a tumor marker. Okay? So again, let me emphasize, no, that the greatest clinical utility or significance of these tumor markers would be for to check, no, for possible recurrence, no, of cancer. Okay? So I think we are down to our last topic, no, for this session. Okay, we have infectious disease serology. Okay, so first we have syphilis. Okay, so syphilis, this is a venereal disease, no, that is caused by Treponema pallidum. Okay, this is caused by Treponema pallidum. Okay, because there are other subspecies of Treponema. No, we have Treponema pallidum subspecies perteniu. We have Caratium, and we have Endemicum. No, so pag specific talaga for syphilis, that is Treponema pallidum subspecies pallidum. No, so for the diagnosis of syphilis, syempre, no, mas ginagamit na lang din talaga yung serological test, no, as compared to the microbiological test, because of course, no, mahirap i-culture kasi, no, itong ating Treponema pallidum. Okay, and syempre, no, not all of the laboratories naman are equipped, no, with dark field microscopy, kasi alam naman natin that we cannot stain, no, spirochetes. Okay, so we opt no for the serological methods no for the diagnosis of syphilis. No, for the serological methods, no, they are divided into two: the non-treponemal test and the treponemal test. And take note na yung mga non-treponemal test, ginagamit lang natin ito to screen no for syphilis. And whenever you have a positive result no for any of the non-treponemal tests, you have to confirm that with the use of treponemal tests. Okay? So, itong mga non-treponemal tests basically no, they are based no on the principle of detecting a reagent. Okay? So ano itong reagent? This is an antibody, no? This is a non-specific antibody directed against cardiolipin that which is a constituent of treponemal lipids but usually derived from its host, no? So kumbaga no, this is a non-specific antibody because hindi lang naman in cases of syphilis na pwedeng magkaroon ng cardiolipin. Okay? Or thus pwedeng magkaroon ng anti-cardiolipin or ng reagent. Because reagent, no, this is also known as, okay, pwede mo din tong tawagin as anti-cardiolipin. Okay? Now, these tests are based on flocculation. Okay? Flocculation reaction. Okay? Wherein patient antibody complexes with the cardiolipin antigen no, present in the reagent. Okay, and here are the list of non-treponemal tests. We have BDRL, RPR, we have TRUS, USR, and RST. No, but we are to elaborate further no sa ating BDRL tsaka RPR no kasi yan yung mga matunog. Okay. So first, okay, we have BDRL. BDRL can be utilized as a qualitative test and it could also be utilized as a quantitative slide flocculation no, test for serum. And the reagent no, that is used no, for BDRL is composed of three components. No? First, we have the 0.03% cardiolipin, which serves as the main reacting component. Kumbaga, ito yung main reagent niya. Okay? Then we have 0.9% cholesterol. The purpose of this is to enhance, no? So it enhances the reacting surface of cardiolipin. Okay? Pakidagdagan nyo na lang dyan. Reacting surface of cardiolipin. Okay? Then we have 0.21% lecithin. This one removes the anti-complementary activity of cardiolipin. Okay, so for the procedure, the serum is heated at 56 degrees Celsius for 30 minutes in order to inactivate the complement. And the rotation is at 180 revolutions per minute for 4 minutes. Okay, so again, no, the rotation is 180 revolutions per minute for 4 minutes. And the result is read microscopically no, for the presence of flocculation. So all reactive sera or weakly reactive results must be tested using the quantitative slide test. Okay? So in modification of the VDRL, no, yan yung ginagamit talaga natin today would be the RPR. Okay? And still, the reagent used here contains the same substances as that of VDRL. So meron pa din talaga siyang cardiolipin, meron siyang cholesterol, meron siyang lecithin. However, no, meron siyang mga additional components. Okay? And the purpose of this is to, isa sa mga pinaka-importante dito is charcoal in order for us to visualize no, the reaction with the aid of the naked eye. Okay, so the purpose of charcoal there is for easy visualization of our results. Yeah. Then we have choline chloride. Okay, the purpose of this is to inactivate the complement. So ito dito malalaman natin na hindi na natin kailangang i-heat pa yung ating serum specimen at 56 degrees Celsius no for 30 minutes kasi meron ng choline chloride no to do that. Okay? Next we have EDTA. EDTA prevents oxidation of lipid. Okay? And we have thimerosal which serves as a preservative. Okay? So, yung RPR, no, as compared to VDRL, this is mostly used as a screening procedure. It is more sensitive as compared to VDRL, however, less specific than VDRL. Okay, so for the procedure, the specimen is still serum. Okay, you are to rotate that for 100 revolutions per minute for 8 minutes. And the results are read macroscopically, no? Thanks to charcoal. Okay? Now, whenever you have a positive result no, for RPR or VDRL, you have to confirm that with the use of a treponemal test. So yung treponemal test naman, no, obviously, yung pinaka-purpose nito is to detect antibody directed against the Treponema pallidum organism or against specific treponemal antigen. So typically, no, these tests are more difficult to perform and are more time-consuming. Thus, they are usually utilized as confirmatory tests. So we have TPI, Treponema pallidum immobilization test. We have the fluorescent treponemal antibody absorption test. And we have heme agglutination test. No? So itong HATS, itong TPHA, tsaka itong MHA-TP, all of these are heme agglutination tests. Okay? So iisa-isahin natin sila. First, we have the Treponema pallidum immobilization test. Okay? So this is the standard treponemal test and is the most reliable. Thus, ito yung ating gold standard no for syphilis diagnosis. So this one involves mixing of patient serum with live actively motile Treponema pallidum extracted from the testicular chancre of a rabbit. So it involves culture. No, kino-culture mo muna itong Treponema pallidum dun sa testicles no ng rabbit, no? Para gamitin mo for the procedure. And the test is considered to be positive if more than, no, or if at least 50% of the treponemes are immobilized, and we are to make use of a dark field microscopy to view it. Okay? So yan yung standard test natin, no? But again, di lahat no ng laboratories are equipped no with dark field microscope. Okay? Kaya hindi siya commonly na pe-perform. Okay? Yung mas common na pe-perform is the fluorescent treponemal antibody absorption test or FTA-ABS. No, yung principle naman nito is indirect, okay? Immunofluorescence. Okay, indirect immunofluorescence. Okay? So this one is highly sensitive and specific but is time-consuming also to perform kasi medyo marami ka din kailangan gawin. No? This test also requires heat-inactivated na serum. So magpe-perform tayo ng complement inactivation by heating the specimen at 56 degrees Celsius for 30 minutes. And we are to do pre-incubation with non-pathogenic treponemes. Because remember, the very purpose of this is to remove cross-reactivity with other non-pathogenic spirochetes. Okay, you might have an anti-treponemal antibody, pero malamang itong anti-treponemal antibody na to is for a treponeme that is non-pathogenic. And we want to remove that possibility by incubating the serum with non-pathogenic treponemes. Ito yung tinatawag natin na sorbent or the writer's strain. Okay, the writer's strain. Ito yung ginagamit kumbaga na sorbent in the procedure. Okay? So after doing the pre-incubation, okay, yung the same sample na sinubject natin for pre-incubation with the writer's strain, okay? Yan din yung ilalagay natin sa slide wherein a virulent strain of treponema is fixed. Okay? Yan yung pinaka-antigen natin for this procedure, and that is the Nichols strain. No? Kasi yung Nichols strain, siya yung pathogenic, siya yung virulent, no? And siya yung naka-affix sa slide. Okay? Now, kung yung patient talaga meron siyang antibody against the virulent strain, those antibodies will not be absorbed sa writer strain and will remain in the sample. Thus, kung ilalagay na natin siya sa slide, didikit siya doon sa Nichols strain sa slide. Paglagay natin ng FITC-labeled anti-human globulin, didikit din doon yung FITC-labeled anti-human globulin. When you wash it off, it will remain. Kaya yung positive result natin dito is presence of fluorescence. Specifically green kasi yung ginamit natin is FITC. Okay? So the slides are read under the fluorescence microscope, and the intensity of green color is graded as 0 to 4. No fluorescence indicates a negative test, and a result of 2 or above is considered reactive. Okay? So that is FTA-ABS. And lastly, we have the heme agglutination test. Pare-pareho lang yan sila ng principle. Okay? Magkakaiba lang yung mga red cells na ginagamit. Okay? So, the antigen used here are red blood cells sensitized with the Nichols strain kasi nga ito yung virulent strain. In the case of HATS and PPHA, gumagamit sila ng glutaraldehyde stabilized, okay, glutaraldehyde stabilized Turkey red cells sensitized with Nichols strain. In the case of MHA-TP, gumamit ng formalinized sheep red blood cells sensitized with Nichols strain. So whenever Treponema pallidum antibodies are present in the serum of the patient, it will agglutinate, basically yung antigen na nakikita sa surface nito mga ginamit na red blood cells, and thus magkakaroon ng agglutination. Okay? So for the interpretation of syphilis results, okay, so RPR mo daw is reactive. So syempre magpe-perform tayo ng confirmatory test, okay? And yung FTA is also reactive. So that means positive ka talaga for syphilis. Okay? Next, RPR is reactive, but FTA-ABS is non-reactive. So ibig sabihin, this is due to biologic false positivity. Okay? Sabi ko kanina, yung nadidetect natin sa RPR is the reagent, and the reagent is not specific for syphilis. It can also be present in other conditions, thus causing biologic false positive result. Ano itong mga conditions na sinasabi ko? Okay? Pwede siyang makita sa SLE, pwede siyang makita sa rheumatoid arthritis, pwede siyang makita sa infectious mononucleosis. Pagbuntis yung babae, pwede meron siyang reagent, and yung sa mga elderlies. That's why, sobrang tanga. Sorry for the term. Medyo hindi tama, Hindi talaga tama, na mag-perform ka ng RPR sa buntis. Kasi magpa-positive talaga yon most likely. Kasi pregnancy is one of the causes of biologic false positivity. Okay? And lastly, RPR is non-reactive, but FTA-ABS is reactive. Ibig sabihin, meron kang late, okay, latent, latent or past infection. Okay? Kasi kahit cured ka na for syphilis, yung antibody against Treponema pallidum will stay in your serum for a lifetime. That's why magpa-positive ka talaga sa FTA-ABS even though you are already free of the infection. Okay? That's why, having said that, that makes VDRL, the test of choice whenever you are to check for recurrence. Okay? Let's say, nagkaroon ka ulit ng reinfection, Nagkaroon ka ng reinfection, VDRL yung test of choice natin. Okay? Kasi hindi ka pwedeng gumamit ng FTA-ABS. Why? Magpa-positive ka na. Nagka-infection ka na kasi dati. So you have your anti-treponemal antibody already. But yung reagent kasi, is only produced if you have the active infection. So if you have reinfection, VDRL is the test of choice. Another, if the specimen is CSF, no, most likely pag CSF yung specimen, we are trying to check if merong neurosyphilis. The specimen is also, or the test also that must be performed is VDRL. Okay? In the ASCP exam, there is a situational question about this, na parang yung medtech daw, nag-perform daw siya ng RPR. Okay? Yung medtech daw, nag-perform daw siya ng RPR from a specimen, from a CSF specimen of a patient who had a positive titer before. Parang nag-positive na sa RPR before yung pasyente. Parang nilagay, kalimutan ko kung ilan yung titer. Basta nagkaroon na daw siya ng positive result, no, of a specific titer for RPR before. Ngayon, nakatanggap siya ng CSF specimen na ititest, no, for syphilis, no, malamang. Ngayon, yung ginawa niya, RPR. No? Nag-perform siya ng RPR and nag-negative yung result. Okay? Ano daw yung gagawin ni Medtech? Okay? I-report niya daw ba yung result? Okay? Uulitin niya daw ba pero mag-hit in activation siya muna? Tatawagan niya daw yung doktor para i-cancel yung test? Or i-preserve niya yung specimen tas hintayin na may dumating na BDRL? Yes, yung medtech na yun medyo tanga. Because number one, you are not supposed to perform RPR, no, in a CSF specimen. Okay? Kasi VDRL lang yung pwedeng i-perform doon. Actually, pwede kang mag-perform ng FTA-ABS but provided there is no blood contamination. Why? Because if you had syphilis, again, the anti-treponema antibody will remain, no, in your blood. Okay? And magpa-positive ka talaga for FTA-ABS sakaling yung CSF mo na-contaminate siya ng dugo. So VDRL lang talaga yung pwede mong gawin, no, for your CSF. Also yung choice na uulitin mo daw yung procedure pero mag-hit in activation ka, no? So another katangahan. Why? Hindi tayo nag-hit in activate ng CSF. Okay? We do not perform heat inactivation for the CSF because the CSF does not contain a significant amount of complement. Okay? So VDRL, no? VDRL yung test of choice natin whenever merong reinfection or CSF yung specimen. Okay? So that's it for syphilis, no? Now let's go to Lyme disease. Okay, so Lyme disease is a condition caused by another spirochete. Okay, and yung spirochete na ito is si Borrelia. No, this is caused by Borrelia burgdorferi. Okay, which is Lyme disease is an arthropod-borne disease, no? Kasi nakukuha natin to sa kagat ng Ixodes tick. Okay, so the diagnosis for Lyme disease follows a two-tiered approach. We have to start with a screening test first, and the possible screening test na pwedeng gamitin would be enzyme immunoassay, no, ELISA, no, or pwede tayong gumamit ng immunofluorescence assay, no, or IFA. Okay, so sulat ko na lang yung buong pangalan. Pwede tayong gumamit ng enzyme, okay, immunoassay, okay. And pwede din tayong gumamit ng immunofluorescence assay. Actually, pwede mo din tawagin yan na fluorescence immunoassay. Ganun pa rin yun. Okay, so that is the standard screening test. And whenever we have a positive result for that, kailangan natin itong i-confirm with the use of Western blot, no? So the confirmatory test, no, for Lyme disease is Western blot. Okay, so the purpose of Western blot is for you to be able to detect IgG and IgM. But nakadepende yan, guys, no, kung how long yung symptoms ng pasyente. Kasi if the days, no, if the symptom, if the signs or symptoms are present for less than 30 days, yung gagawin mo is the IgM, IgG Western blot, no? Pag less than 30 days, no? Pag less than 30 days, yung gagawin mo is IgG and IgM Western blot. But if the signs and symptoms are already present for more than 30 days, okay, malamang wala na yung IgM, so you go for the IgG Western blot only. Okay? Now, sir, what if nag-negative? No? What if nag-negative yung screening test? Negative na ba yung pasyente? Hindi pa. Okay? Hindi pa. Pag nag-negative yung screening test, okay, pag nagkaroon ng negative result, yung enzyme immunoassay or immunofluorescence assay, you consider an alternative diagnosis. Or if the patient really has signs and symptoms that are consistent with Lyme disease, okay, but less than 30 days pa lang naman, you consider retesting a convalescent serum. Kasi baka nag-negative kasi wala pa siya masyadong antibodies. Okay? So again, pag nag-negative, no? Pag nag-negative yung result, you consider an alternative diagnosis. Okay? Or you consider pag sinabing you consider an alternative diagnosis, you look for other possible disease na na what do you call this? Other possible disease no sa pasyente, or okay, you consider retesting for a convalescent specimen if yung signs and symptoms talaga ng pasyente consistent talaga na Lyme disease yung sakit niya. Okay? Now, for the Western blot confirmation of IgM antibody, you only need two out of the three bands. No? So we have 24, 39, and 41 kilodalton bands. And for IgG antibody, you only need 5 of these bands. No? So pag nag-positive ka sa 5 dyan, so that means no, positive na for the IgG antibody. Now, if serology is negative and symptoms are consistent with Lyme disease, ito yung sinasabi ko, a convalescent serum should be obtained and tested. Okay? So that is for Lyme disease. Next, let's proceed to Group A streptococcal infection. Sino again yung Group A na ito? This is Streptococcus pyogenes. Okay? Streptococcus pyogenes. Now, siyempre yung pinaka-test natin for Streptococcus pyogenes would be the anti-streptolysin O or yung tinatawag natin na ASO titer. Okay? So we are detecting the titer value in quantitative measurements of positive results. So one has to perform a serial dilution method no, or technique in order for you to be able to get the titer. So the normal value of the ASO or the anti-streptolysin O level is usually less than 160 TOD units. However, if the person had a streptococcal infection, pwedeng umabot yan no, ng greater 240 TOD units. Okay, TOD units pag adult yung pasyente. Okay? And pwede siyang umabot ng greater than 240 and greater than 240 and greater than 320, okay, TOD units, okay, in the case of children. Okay? So yung mga methods natin dito would be latex, no, which of course follows passive agglutination na procedure kasi yung latex i-coat mo siya with the antigen no of Streptococcus pyogenes. And we also have the hemolytic test. Ito yung classic test natin, di ba, to detect the titer. So this is based on neutralization principle of the patient antibody. Na kung yung patient meron siyang antibody against anti-streptolysin O, this antibody will basically fix the streptolysin O, preventing hemolysis. Therefore, okay, yung chine-check natin sa hemolytic test is we are looking for the tube, okay, with the highest dilution, the tube with the highest dilution, okay, showing no hemolysis. Yeah. However, no, hindi sa lahat ng oras na nagkaroon ng streptococcal infection yung isang tao, magpa-positive talaga siya sa ASO or sa anti-streptolysin O. Sa katunayan, there is a procedure that is often performed no, sa mga anti-streptolysin O negative individuals. Pero malakas talaga yung suspetsa na nagkaroon siya or meron siya nitong streptococcal infection. No? So ano daw yung test na yon that are performed or that is performed? Okay? A test that is performed no, for ASO negative patient, that is anti-DNase B. Okay? Anti-DNase B testing. So this is performed, okay, on ASO or anti-streptolysin O negative patients, okay, na presenting no a considerable evidence na meron siyang streptococcal infection. Okay, so we're done with Streptococcus pyogenes. Let's now proceed no sa mga viral infection. First, we have infectious mononucleosis. Okay, so first we have here the characteristic diagnostic profile of EBV or Epstein-Barr virus. Okay, so you are considered to be susceptible no, to the infection if you are seronegative or you have no antibodies no, to VCA. So that means you were never exposed, okay, to Epstein-Barr virus, and thus you can be infected kasi wala ka ding immunity. Okay? Then we have primary infection. Okay? So you have an antibody, okay, IgM to VCA is present, but EBNA is absent. And you also have a high or rising antibody to IgG, to VCA, that is IgG in nature, and no evidence of antibody to EBNA after at least 4 weeks of symptoms. No? So that is primary infection. No? Anyway, we have a table later no, for the serological responses of patients with EBV-associated disease. Then we have reactivation. No? So pag sinabi natin reactivation, you had the convalescence already. No? Ibig sabihin parang na-cure ka na. Thus, meron ka ng EBNA. No? Meron ka ng anti-EBNA because anti-EBNA is only present during convalescence or produced during convalescence. Then you have increased antibodies to EA. No? Because EA are usually present lang pag merong acute phase or active infection. And the patient may be experiencing reactivation in such case. No? And lastly, if you had a past infection, you have antibodies to VCA, specifically IgG, and you also have anti-EBNA. Okay? So, yan siya. Okay? So, ano ba itong mga EBV antigen-specific serologic test natin? No? Kailangan natin silang kilalanin kasi syempre through this malalaman natin kung ano yung mga possible profiles of a patient no given a particular condition. Okay, so first it appears at onset of symptoms, however it disappears in 3 months. No, yan yung anti-VCA, no, anti-VCA na IgM. Okay, VCA means viral capsid antigen. Okay, next we have appears at onset of symptoms. Sa katunayan, mas mataas pa yung level nito during the acute phase. Okay? And however, it persists for life. No? That is anti-VCA IgG. Next, also seen during the acute phase, we have anti-EA. Okay? Then we have present during convalescence, we have anti-EBNA. Okay? So there I have included no the different serologic responses of patients with EBV-associated disease. Guys, pakilagyan ng star, importante, no? There's a recall na parang naglagay sila ng iba't ibang mga antibody, tas nilagyan nila ng titer, tas pina-identify sa iyo yung sakit ng pasyente. Okay? So, importante ito. Okay, so first we have the anti-VCA na IgM, IgG, tsaka IgA. We have anti-EA, anti-EBNA, tapos we have heterophil antibody. Okay, yung heterophil antibody na yan, that is an IgM, remember. Kaya nga nagkukos yan ng cold agglutinin disease, di ba? So if you are uninfected, so you are seronegative. Natural, negative ka sa lahat. Di ba? If you have acute infectious mononucleosis, you will be positive for IgM na anti-BCA. Okay? Tapos, mataas pa, di ba? Sabi ko, mas mataas pa ngayon titer ng IgG during the acute infection, no? Of acute infectious mononucleosis compared to IgM. Then you may or may not be positive for IgA. Positive ka for early antigen diffuse. Negative ka for early antigen R. Negative ka for anti-EBNA kasi hindi ka pa naman nag-convalescence. Pwedeng maging positive or negative ka sa heterophil antibody. Next, for convalescent infectious mononucleosis, convalescent na. So, syempre, negative ka na for IgM. Again, yung IgG, it persists for life. Okay? Negative ka for IgA na anti-BCA. Negative ka for the early antigen diffuse. Pwedeng maging positive ka for EAR. Siyempre, positive ka na for anti-EBNA kasi convalescence na. And pwedeng positive ka or negative for heterophil antibody. If you had a past infectious mononucleosis infection, negative ka for IgM. IgG remains for life. Okay, negative ka for IgA. Negative ka for the early antigen because you do not have the infection anymore. Okay? Tapos magpa-positive ka sa EBNA kasi naranasan mo na yung convalescence. And negative ka din for heterophil antibody. If you have a chronic active infectious mononucleosis infection, you will be negative for IgM kasi chronic na siya. Sobrang taas ng titer ng IgG mo. Okay, magiging positive or negative ka with IgA. Positive ka with the early antigen. Okay, positive ka din with EAR. And pwedeng maging positive or negative ka with anti-EBNA, but negative ka na for heterophil antibody. Okay? For post-transplant lymphoproliferative disease, negative for IgM, pwedeng maging positive, no? Positive ka talaga, no, for IgG. Pwedeng maging positive for IgA. Positive ka for EAD and EAR. Pwede kang maging positive for anti-EBNA, but negative ka for heterophil antibody. Next, we have Burkitt's lymphoma, negative for anti-BCA IgM, a strong positive result for anti-BCA IgG, negative for anti-BCA IgA. You may be positive for anti-EA, positive ka for EAR, okay? Positive ka for anti-EBNA, negative ka for heterophil antibodies. And lastly, we have nasopharyngeal carcinoma, negative for IgM, a strong positive result for IgG, positive ka for IgA, positive ka for EA diffuse, you may be positive for EAR, positive ka for EBNA, and negative ka for heterophil antibodies. Okay? So that's it, no, for pwede kang bigyan ng result tapos ipa-identify sa iyo, no, kung ano yung kalagayan ng pasyente. Okay? So that's it for infectious mononucleosis. We now go to hepatitis A infection, no? So infectious hepatitis. So very important. Ito kasi yung recall dito, yung pagkakasunod-sunod, no, ng mga markers, no? So yung HAV antigen, no? So this is shed in the feces of infected individuals during the early acute stage of infection. Then we also have, no, the IgM anti-HAV. No, this is the marker of acute hepatitis which peaks during the first month of illness. Then we have the IgG anti-HAV. It is produced as a result of natural infection or immunization. And syempre, no, it lasts, no, sa ating serum, sa ating plasma, no. That's why if you had hepatitis A, it will guarantee you a lifelong immunity. Okay? So yung naging recall question sa exam, ano daw yung tamang pagkakasunod-sunod, no, ng mga markers? So first, no, stool HAV muna bago magiging detectable yung IgM anti-HAV, and lastly yung IgG anti-HAV. Parang meron ding recall question dito na negative daw siya sa IgM anti-HAV, tas positive daw siya sa IgG anti-HAV. Ano daw yung gagawin? Wala. Ibig sabihin immune yung pasyente. 'Di ba? Kasi wala naman siyang infection, kasi negative na siya for the IgM, 'di ba? So immune na talaga siya kasi nga meron na siyang IgG. Okay? Next, we go to hepatitis B. This is another important topic, okay, for immuno. Serology, we have the different markers for HBV infection. No? So we have HBsAg, which is only positive for active hepatitis B infection. We have HBeAg, no? A marker for infectivity. So pag nag-positive ka dito, sobrang nakakahawa ka. Okay? Then we have the IgM anti-HBC. Okay? This will become positive for current or recent acute hepatitis B infection. Okay, and this is the sole marker of acute HBV infection, yung IgM na anti-HBC. So, ibig sabihin, this is the only marker na magiging positive during the window period. Okay? Next, we have IgG anti-HBC. This persists for the individual's lifetime. That means pag meron kang anti-HBC, ito talaga yung magsasabi sa iyo that you were exposed to the real virus. Okay? Next, yung total anti-HBC, of course, that is the combination of both the IgM and IgG anti-HBC, and it might indicate current or past hepatitis B infection. Anti-HBs is a marker for immunity, and pwede tayong magkaroon nito by by vaccination lang, di ba? Or pwede ka ding magkaroon nito because of the natural infection. And HBV DNA, this is the viral load. Okay? So usually ginagawa ito if you have acute, atypical, ibig sabihin medyo weird na uri ng hepatitis B infection or occult hepatitis B. And this is also being tested. Alam naman natin yung lahat, na yung viral load, yan yung chine-check to assess effectiveness of therapy. Okay? So pinaka-importante dito, marunong tayo mag-interpret ng hepatitis B panel. So first, patient. Hepatitis B S antigen negative. Negative siya for anti-HBC, negative siya for anti-HBs. So paano natin to gagawin? Uy, negative siya for HBsAg. So ibig sabihin wala siyang infection. Anti-HBC negative siya, ibig sabihin hindi siya na-expose. Anti-HBs negative siya, ibig sabihin wala siyang immunity. So yung taong ito ay susceptible. This person is susceptible kasi never pa siyang na-infect and wala din siyang immunity. Okay? Next. Patient is HBsAg negative, therefore wala siyang current, wala siyang active infection. Anti-HBC positive, ibig sabihin na-expose siya. Anti-HBs positive, ibig sabihin immune na siya. So ano to? This is immunity, okay? Immune due to natural infection. Okay? Pangit naman ang gamitin yung term na natural. Immune due to infection. Okay? Na-infect talaga siya ng virus, kaya nag-positive siya sa anti-HBC. Next, HBsAg negative, anti-HBC negative. So HBsAg negative, walang active infection. Anti-HBC negative, never exposed. Anti-HBs positive, may immunity. Meron siyang immunity pero hindi siya na-expose. So malamang nakuha niya because of vaccination. Immune due to vaccination. Okay? Next, HBsAg positive, anti-HBC positive. HBsAg positive, ibig sabihin may active infection. Anti-HBC positive, ibig sabihin na expose. IgM anti-HBC negative, ibig sabihin hindi early or hindi acute phase. Anti-HBs negative, wala siyang immunity. So hindi siya acute, ibig sabihin this is a chronic active infection. And remember guys, no, remember that as long as you have HBsAg, you won't produce anti-HBs. Okay? Now, meron tayong mga atypical results, no, na medyo may mga weird na hindi natin siya kayang ma-categorize dun sa una nating apat na napag-usapan. Okay? Example, HBsAg mo negative. Anti-HBC mo positive, ibig sabihin na-expose ka. Anti-HBs mo negative, wala kang immunity. Na-expose ka na, tas wala kang immunity, tas wala kang active infection. So medyo mahirap siyang i-interpret. So here are the 4 possible interpretations of this result. Number 1, you might be recovering from acute HBV infection. Nagre-recover ka pa lang siguro, kaya hindi pa mataas yung titer ng anti-HBs mo. Number 2, might be distantly immune. And immune ka na, ibig sabihin may anti-HBs ka na talaga, pero hindi lang sensitive enough yung procedure para ma-detect yung konting amount ng anti-HBs mo. Number 3, might be susceptible. Ibig sabihin, never ka pang na-expose, tas false positive lang yung anti-HBC result. And number 4, you might have undetectable level of HBsAg present in the serum and you are actually chronically infected. Kasi di ba pag chronically infected ka, anti-HBC positive ka. Okay? Tas anti-HBs negative ka. Tas malamang hindi mo lang na-detect yung HBsAg na present sa serum ng pasyente. Okay? So those are the 4 possible interpretations for that result. Okay? And we now go to the last viral infection. We have HIV infection. And we all know that the primary target of HIV virus is are our CD4 positive cells as well as the macrophages, no? Because some macrophages might also possess this CD4 in their surface. Kasi yung CD4, yan yung receptor ng virus. Okay? So, other than the CD4, there are other mediators, no, or substances, no, present in the surface of certain cells that mediates, no, or promote the entry of the virus into these host cells, no. So we have CXCR4 and CCR5. Okay? I think importante, no, na malaman natin itong mga structural genes of HIV. Okay? And ano-ano ba yung mga proteins, no, that are originating from these genes, no. So first, okay, the gene that codes for P55, a precursor from which 4 core structural proteins are formed. Okay? So ito yung ating GAG, no? The GAG gene. So yung GAG gene, ito daw yung nagko-code kay P55. Tas galing kay P55, we have P24, no? We have P24, we have P6, and we have P9 that are located at the capsid or in the capsid. Then we have P17, no? P17 that is found in the layer between the protein core and the envelope matrix. Okay? Next, codes for glycoproteins GP160, GP120, and GP41. Yan naman yung ENV, no? The ENV gene. So the precursor protein, no, that is oftentimes cleaved, no, to form GP120 and GP41 is GP160. So kumbaga, yung GP120 tsaka GP41 sa kanya yan nanggagaling whenever it is cleaved. The GP120, okay, the GP120 forms the numerous knobs, okay, or spikes that protrude from the outer envelope, no, of the virus. And yung GP41 is a transmembrane glycoprotein that spans the inner and the outer membrane of the virus. And lastly, we have the Pol gene, which codes for the enzymes necessary for HIV replication. Kasi without these enzymes, no, HIV will not replicate. Pinaka-importante dito and is the target of antiretroviral therapy is reverse transcriptase. Okay? Reverse transcriptase. Okay? Reverse transcriptase is actually P51. Okay? Next, Degradation of the original HIV RNA. So, i-degrade niya kasi gagawin niya yung DNA with the use of reverse transcriptase. That is your ribonuclease. Okay, ribonuclease or otherwise known as P66. Next, the one that inserts viral DNA to host's DNA. So, ini-insert niya, kumbaga ini-integrate niya. So, that is integrase. Okay? Integrase. And integrase is P31. And lastly, cleaves precursor proteins into active units. That is protease. Okay? And that is P10. Yeah. Okay? Now, let's talk about the kumbaga, no, the flow of HIV infection. So first, we have primary infection. So during the primary stage of infection, there is high levels of virus in the blood, no, or viremia. So the patient, no, that has acquired, no, the infection might experience flu-like symptoms, fever, lymphadenopathy, sore throat, joint pains, muscle pains, fatigue, rash, and weight loss. Ito guys yung tinatawag, no, na acute. Okay, these symptoms is the characteristic of acute retroviral syndrome. Okay, acute retroviral syndrome. However, not all patients will be able to experience this. No, this is only experienced by 50 to 70% of patients who acquire the HIV infection. Okay? So, these symptoms, no, characteristic of the acute retroviral syndrome will oftentimes resolve, no? Yes, it appears within 3 to 6 weeks after infection, but oftentimes it will resolve, no, within 7 days. Okay, it resolves within 7 days. Next, the clinical latency, no? So hindi na to kailangang i-explain. Yung clinical latency, ito yung tinatawag na window period. Wherein yung pasyente wala siyang nararamdaman pero okay, positive siya, no, for positive siya whenever tested. And syempre, the patient is also seroactive. Ibig sabihin, pwede siyang makahawa. Okay? And lastly, no, the AIDS, no, AIDS, no, or acquired immunodeficiency syndrome, wherein, no, there is already profound immunosuppression, and the patient is already experiencing life-threatening infections. Okay, and this is characterized by an absolute CD4 cell count of less than 200 per microliters. Okay, now, paano ba yung order of appearance of the HIV markers? First, no, the viral RNA that is detectable within days of the infection. Then we have the P24 antigen, which is a core coat for nucleic acids, is detectable in 2 to 3 weeks, no, after the infection. However, it becomes undetectable as soon as antibodies are developed. Then it will become detectable again in the late stages when the immune system starts to drop again and the virus will start to replicate again. Okay? So si P24, detectable within 2 to 3 weeks, tapos mawawala, tapos babalik ulit pag bumaba na naman yung immune system ng pasyente. Okay? Next, we have IgM antibodies. They are usually detectable in 2 to 8 weeks. Okay? 2 to 8 weeks. Okay? And they are transient and peaks in about 1 to 2 weeks and undetectable na naman siya about 1 to 2 weeks later. Okay? Transient lang. Ibig sabihin, it won't last. And of course, no, the IgG antibodies, which become detectable shortly after the IgM, and siya yung long-lasting, which titer, no, gradually increase, no, over several months. So yan yung pagkakasunod-sunod. So mas nauunang nadidetect yung viral RNA. Okay? Now, let's go to the algorithm, no, for HIV screening and diagnosis. So first, we have HIV antibody detection. So for the screening test, the standard screening test is ELISA. But other than that, we have microfiltration enzyme immunoassay, and we have agglutination tests, which could make use of latex, gelatin, or microbead particles. The standard confirmatory test is Western blot, pero pwede din confirmatory yung immunofluorescence assay as well as radioimmunoprecipitation tests. Okay? So paano ba ginagawa yung Western blot? Okay? The equipment or the parang reagent no needed no are prepared commercially as nitrocellulose or nylon strips containing individual HIV proteins. So any HIV antibodies present will bind to their corresponding antigen on the test membrane. Kasi may mga protein na doon, eh ba? So meron na mga P55, meron na mga P24 and the like, no? And if you have an antibody against them, if you have anti-P24, anti-P55 for example, it will bind to those antigen and it will be visible as bands later on. So as a result should be reported as positive if at least 2 out of the 3 bands are present. Actually guys, 4 na yan ngayon. Okay, so as long as dalawa daw, no? As long as dalawa present sa 4 na yan, that is considered positive. Para ma-consider ka na negative for HIV, dapat wala ka talaga any of the bands. Okay? And pag isa lang, no? Pag 1 out of the 4 bands, you are considered to be indeterminate. And pag indeterminate, ano yung gagawin? Okay, testing must be repeated on a later date. Kasi most of the indeterminate patients will test positive after some time. Okay? So ano daw yung mga proteins na didetect dito? We have GP120, 160. So they are counted as 1 ha. They are counted as 1. So GP120, 160. Okay? We have GP41. We have P24 and P31. Okay, P31. So yan sila, no? Again, if indeterminate, no? Indeterminate yung result. Okay, if the result is indeterminate, ibig sabihin isa lang yung band. Ano yung gagawin? Repeat test on a later date. Okay? Now, next we have qualitative nucleic acid tests. Okay? So yung qualitative nucleic acid test is used to determine whether or not a detectable level of HIV nucleic acid is present in human plasma. Kanina kasi yung nasa taas, itong ELISA at Western blot, yung dinidetect natin doon are the HIV antibodies. Okay? But this time, we are detecting for the genome, no, of HIV. So this can be used, no, to screen or make an initial diagnosis, particularly beneficial in cases where serological results are inconclusive. Sa katunayan, no, yung test, no, na pine-perform to be able to diagnose HIV, no, sa mga infants is a qualitative nucleic acid test, no. To be specific, yung tawag natin sa test na yon is qualitative, okay, qualitative, okay, HIV-1 DNA PCR test. Okay? So, yung procedure na ito, no, yung nagdi-detect siya ng pro-viral DNA, and this is often used, no, to diagnose infants, no, of less than 18 months of age. Okay? Na less than 18 months. Okay? And of course, no, if a person is already diagnosed of having the HIV infection, remember, no, that the person could still live a normal life provided na maintain lang or na itataas ulit, no, yung CD4 count. Okay? So, part of the HIV disease monitoring, of course, is the CD4 count. Okay? So, CD4 T cell enumeration, the normal value for CD4 is 500 to 1,300 cells per microliter. And the ratio of CD4 to CD8 should be 2:1. However, no, if the person is meron na siyang AIDS, 'di ba? Sabi natin kanina, yung count niya magiging less than 200 cells na lang per microliter and nagkakaroon siya, no, less than 200 cells na lang, okay, per microliter, and nagkakaroon siya ng inverted, no, inverted ratio. Okay? So pag sinabi nating inverted ratio, mas marami na, no? Mas marami yung CD8 as compared to CD4. Not because dumami yung CD8, but because bumaba yung CD4. Kasi yun yung mga ginagamit. Remember, no? CD4 positive cells are the ones used by HIV to replicate. Okay? So usually the ratio, no, will become 0.5 to 1. Okay? Giging ganyan yung ratio. Then, the gold standard, no, for enumerating CD4 positive T cells would be immunophenotyping. Okay? Immunophenotyping. Siyempre, detect mo yung CD4. Okay? With flow cytometry. Kasi yung flow cytometry, ito yung kakailanganin mo to analyze the data. Okay? Now, include ko na lang, no, kasi baka ipasolve sa inyo, no? Bigyan kayo ng, let's say, case and ipasolve yung percent CD4 T cells, no? So how do we get that? Okay, percent CD4 T cells. Okay, so that would be number, no? Number of CD4 positive na lymphocytes, lymph, divided by the total number of lymphocytes. Okay, total number of lymphocytes times 100. Okay? So, that's how you solve for the percent CD4 T cells. Now, if you need to solve for the absolute, okay, you need to solve for the absolute, okay, CD4 T cells. Okay? Absolute CD4 T cells. How do we do this? Okay, that would be your WBC count. Okay, WBC count multiplied by your percent lymphocyte. Ibig sabihin yung yung relative count natin, yung nakukuha natin sa diff count, no? Yung percent lymphocyte times the result for the percent CD4 positive T cells. Okay? So that's how we solve for the absolute CD4 count. Okay? Another, no, it's not just enough to check for the CD4 count, no, minsan, no, that is oftentimes partnered with quantitative viral load assay, no, or tinatawag lang talaga siya na viral load kasi dito nalalaman if whether nagiging undetectable na yung pasyente, no? So, the patient is considered to be undetectable. That really depends on the procedure being used, no? Kasi mayroong mga procedure na very sensitive na kaya niyang ma-detect kahit 20 na lang na virus per ml, kaya niya pang ma-detect. Merong iba na 50, yung pinakamababa na kaya niyang i-detect. So, nakadepende sa method. Kasi, let's say, your viral load is already 20, but the method used has a sensitivity of 30, then you will be reported as undetectable. Kasi you are already below the sensitivity of the method used. Okay? So, that's the quantitative viral load assays. And meron tayong dalawa na pwedeng gamitin dyan. We have PCR and pwede tayong gumamit ng branch chain DNA analysis. Okay? PCR and branch chain DNA assay, for example. Okay? And yung PCR, ano yung principle nito? Target, no? Target amplification. Okay? Target amplification. Okay? And pag branch chain DNA assay, signal naman to, no? So this is an example of a signal amplification method, okay? Na ina-amplify mo yung signal that is produced because of the reaction, no? So you are amplifying the signal that is produced because of the reaction. Okay? So that is quantitative viral load assays. And lastly, no, we have drug resistance testing, no? Pwede kasing maging problema, no, itong drug resistance when it comes to HIV. Hindi lang naman bacteria pala yung nagde-develop ng drug resistance. Okay? So we could do two approaches, no, for drug resistance testing. Yung pwedeng i-detect mo yung mismong mutation, no? You detect a mutation in the protease or in the reverse transcriptase gene, no, of the the virus, no? So tawag natin doon kasi dinidetect mo yung mismo mutation, that is the genotype uh, test, no? The genotype test, no? Wherein you are detecting the mutation. Pero pwede ka din gumawa nitong phenotype test. Pag phenotype test, what you're going to do is you check the ability, no, of the HIV isolate to grow even in the presence of ARV. Okay? So you check the ability of isolates. Okay? Check the ability of isolates to grow, okay, in the presence, okay, of ARV. So pag yung virus tumutubo pa rin kahit meron ng antiretroviral drug, patay. Ibig sabihin, resistant siya, no, to the medication used. Okay? So yan po, no, yung course, no, ng HIV diagnosis and monitoring. Okay? And I think, no, that ends our session for today. Thank you.